Good morning. This is Dr. John Bennett broadcasting from dark Miami. This is another in the series of pediatric neurosurgery conferences, Neurosurgical TV in collaboration with Deepak Gupta of the Department of Neurosurgery of the AIIMS Hospital in New Delhi. We have the pleasure today of having a neurosurgical superstar, Ike Cherian, MD, from Nepal, originally from India, but he's practicing now in Nepal. We're glad to have him here today. But first, let me introduce the panel before I turn over to Ike. Good day, Francesca.
Good evening, Professor. I'm Francesca Ochia. I'm a fifth-year medical student from Bucharest, Romania. And I am really excited to see what Dr. Cherian has to tell us about pediatric trauma.
Yes, pediatric trauma.
Thank you. I think this is a fascinating subject, and is something that every doctor should know, because we will encounter a traumatized child at least once in our practice.
Very good. Welcome, Francesca. Welcome. And Dr. Gupta?
Hi, welcome. I look forward to your talk on pediatric head injury. We all know that 1/3 of the world population of children lives in India, and there is no part of the world which is immune to traumatic injuries in children. And it will be very exciting to listen to your thoughts on how you manage children with traumatic brain injury. I look forward to your talk.
Okay, very good. Okay, it's all yours, Ike. Welcome.
Yes. See, morning, guys. It's an honor. And thank you for inviting me, Deepak. So, at the outset, I would like to tell you that my management of pediatric head injuries has not been the same as the rest of the world manages. For example, we have started off with this thing, cystonostomy, and so there's a lot of fundamental differences and a lot of change in beliefs that we have. I'm sure a lot of people may not accept it, some may accept it, but I'm just going to tell about our view of treating pediatric head injuries. And I would invite Deepak, because Deepak is an expert on pediatric head injuries, so I would also like to learn from Deepak as to how he differs or how he manages things differently. So I would like to let me start off by screen sharing, John. I hope.
Okay, let's check it out.
Yes, let's share the entire screen.
Okay.
Are you seeing my screen?
No, not yet. Not yet. You share me. You're not sharing your PowerPoint.
Okay. Are you seeing my?
Yes, I am. Pediatric head injuries.
Right.
And let me know when you change slides to make sure we see the change also.
Yeah.
Okay.
Okay. So let's get into the matter straight. How different is a pediatric head injury from adult head injury? Well, I mean, there's not much of difference, but there's a hell of a lot of difference too. How's that? Now, the first thing is an extradural or a depressed fracture or any other kind of head injuries is different in pediatrics because, number one, the amount of blood loss can only be minimal. Not in surgery, even during the head injury. If there's a lot of blood loss, by the time the child comes, hello? Can you hear me?
Yes, we can hear you very well.
Yes, we hear you.
Go on.
Hello?
We hear you well. Yes.
Yeah, so the amount of blood loss is a very important thing in pediatric head injuries. So that's one thing you need to be taking care of in additional to how you would manage adult head injuries. Now there's some bad news and good news, as I have written. The bad news is you see this thing that these pediatric brains, they tend to swell up, that too suddenly, without hardly any structural damage. And if there's a subdural or something, everything will be fine, and suddenly they go for a massive swelling. When you open up, there'll be, the malignant brain edema, as you put it. I really see that in pediatric brains. I would like to see what's Deepak's view on that. But we don't give mannitol, or we don't give any hypertonic saline for these patients. I mean, even when we are watching them and the GCS is good, we don't give them any prophylactic mannitol or hypertonic saline. Now, the good news about pediatric head injuries is that the children's brain have amazing plasticity. So if the child manages to survive, the child usually does good. So with this background, we will see what's usually done. So usually you do a ICP monitoring and ICP based management. Most of the head injuries are managed conservatively, and when there is a need, we go for a decompressive craniectomy or lesionectomy. And in my center, we used to do that for some time. Then we started doing decompressive and cystinostomy, and then now we do cystinostomy alone. Now, what's the difference? The difference is very simple. Earlier, we used to remove the bone, and then we used to remove the bone as well as open the cisterns. And now we remove the bone, but after we open the cisterns and the brain is lax, we put the bone back. So, I mean, that's how we manage. Now, let's look at some proposed mechanisms. These two words, the CSF shift edema and lactate clearance, is very important. I'll get to that once. Now, can you see that, John?
Hold on.
Can you see the drawing?
Yeah, not really.
Yes?
No. What do you want to show?
No, can you see the drawing?
Yes, I can. Now that I see your drawing, yes.
Everybody can?
Yes.
Okay, right. So, just drawing the brain here. This is one thing I would want to discuss in detail. So that's why we would. So we all know that the CSF gets secreted in the lateral ventricles, the third ventricles, and the fourth ventricles. And then we also know that you have the cisterns here and all around too. The CSF space is all around. We have the cisterns here. So let me just fill this up. Right. Now, one more thing that we know is there are vessels in here. Now the vessels go from the cisterns into the brain, and then they branch. Then you also have vessels along the brain, and they branch too. Now, right. So when, let's say this is a normal brain, and let's say that there's trauma. So in trauma, what happens? the most common thing that happens in severe head trauma is subarachnoid hemorrhage. So when you have subarachnoid hemorrhage, you have these small vessels bleeding into the cisterns. Well, there will be contusions, there may be subdurals, there may be convexity subarachnoid hemorrhages, but one of the most important thing for me, what happens is this: there's bleeding into the cisterns. And when the bleeding into the cisterns happen, what happens is the cisternal pressure, the pressure in these cisterns, they go up. And they go up significantly because the pressure in the cisterns are usually about 10 to 15. And we are talking about a capillary bleed, we are not talking about pure arterial bleed, so let's say it goes to 50. The pressure in the brain, on the other hand, is going to remain, let's say, around 20. So there's a gradient between the cistern and the brain. Now cisterns are CSF, the brain itself is brain matter. Now, do they communicate? That's been proven clearly with the G lymphatic system that the cisterns, they travel through the paravascular spaces. These are spaces accompanying the vessels. So they travel around the paravascular spaces to all parts of the brain. So if you take a vascular cast, that's exactly where your cisterns, your CSF is too. And also that they communicate with the interstitial fluid of the brain. There are other functions for it too, but right now we know that this paravascular spaces carry CSF from the cisterns and they communicate with the interstitial ISF, brain ISF. They communicate with the brain ISF. Does the ventricular fluid communicate with the brain ISF? No. So the ventricular fluid is in the production phase. The ventricular fluid comes down all the way to the cisterns, and from the cisterns, the CSF goes up, accompanying the vessels and communicating with the brain ISF everywhere. So when the cisternal pressure goes up, these are actually, these channels are aquaporin 4 gated, AQP4 gated. But when the pressure in the cistern goes up, so much so that you have 50 and about 20 there, you will have fluid shifting massively through these paravascular spaces. It will result in a picture like what I'm going to show you right now. So I'm going to show you a picture after that shift. Let's do it in a simple way. This was the initial picture, and the next picture would be no cisterns, brain edema. I'm sorry, this is not very bigger than this, but let's make it like that. Let's make it. This becomes big. This becomes big, and the cisterns, they have discharged there. So this has become big. But you must understand that the cranial cavity is unyielding. The cranial cavity is unyielding. Let's put the yellow cranial cavity, or let's put a green cranial cavity. Let's put the green cranial cavity there, like that. So this brain becomes edematous, the cisterns disappear, and because this brain cannot expand, according to Boyle's law, the pressure goes up. When the pressure goes up, the cerebral perfusion pressure comes down, and then it will result in all the other problems like ischemia, infarct, and other problems. So this is the proposed mechanism that we're looking at. Now, let's say you have a brain like that. It's edematous, really angry, bursting out. There's not much of cisterns there because the cisterns have already discharged all the fluid into the brain. The solution, right now what we do is to make a craniotomy large so that we allow this this brain to come out, herniate out. So,
hello.
Hello. Here the pressure comes down.
Good afternoon, sir.
Here the pressure comes down, but the problem is this brain gets stretched. This brain gets stretched, all the axons get stretched, and once the edema is down, the brain is only half its size, like that, something like that. You see that in a decompressive hemicranectomy that everything collapses because the severe axonal stretch injury, and this is what is usually happening right now. So what we propose we are going back to the same stage where you have brain edema, you have cisterns are almost nil, nothing, no cisterns there because the brain is edematous. What we propose was that you open this. So once you open this, the pressure in the cisterns come down, and this gradient which had driven this CSF in the first place will reverse, and this brain edema comes down. This is what we proposed, and we see it during surgery. And when you open the cisterns, there's a lot of blood first. There's a lot of blood initially, and then once the blood is taken out, you have CSF coming out, and the brain edema rapidly comes down. The only difference I have seen in children is that if in adults it is extremely difficult to get into the base, it is 10 times more difficult in children to get into the base. So how do you do that? How can you get into the base? Well, after we always do a large, really big flap like a decompressive hemicranectomy, and if it is really difficult, if it's very difficult, then we don't even mind sacrificing a bit of orbitofrontal gyrus, maybe 1 centimeter of strip through which we even suck that out so that we get a little bit of space. Once you get into the cisterns, it's a different story. So the brain, I mean, once we open at the base, we are going to be opening right at the base, because after our in children we don't do any fancy skull-based maneuvers, because you just take a large decompressive hemicranectomy, bite as basal as you can, and then you just get in here. Instead of doing opening here, you get in here, and here is your orbitofrontal gyrus. So when you retract the orbitofrontal gyrus, you are going to get into the orbitofrontal gyrus and you're going to get into the systems fast. Once you get into the systems, the brain edema is less. Now, the advantage of Google Hangouts is that I can probably stop right now and then I'm going to ask Deepak as to what his view is on this, because it's very valuable, because I'd like to know as to what is Deepak's view on this. I'm going to stop.
Well, what you are saying is makes sense and quite understandable. However, I manage these children a bit different. I am one of the old-fashioned neurosurgeon, you can say. This cystonostomy mechanism, which you have hypothesized and which you are talking about, it makes sense, and well, it is true what you're talking about. However, I differ slightly in my approach. What I do is I give a lot of hypertonic saline to my kids with severe TBI. I don't give any mannitol. I do ICP intra monitoring in all my children with severe TBI. And the thing I do differently is that I put external ventricular drainage in all my children. I have reached a conclusion that it is very, very easy actually to hit the ventricles, even in the swollen brains. You just have to be closer to the midline and being back vertical in front at the coronal suture. So most of my residents are ventricles, and actually guides me whenever I see some spike of ICP. Instead of giving hypertonic saline, I just open the EVD and just continue with the monitoring. So when there are no 8 hours, then I take off the ICP monitoring. We are a part of a major international study which is called ADAPT study. It's approaches and decisions in acute pediatric TBI. And so we are following the protocols. And now after the institution of the protocolized management of these children, I'm very happy to inform, as per the data being provided to my by research fellow, we lost only 6 children out of 70 children. That means the mortality in severe TBI was less than 10%, which probably was not heard of. So it really does not require any rocket science to improve the outcome. You have to stick to the protocolized treatment. The other myth which is there in the management of these children, a lot of these people, the neurosurgeons, they usually give even 5% dextrose to these children. I would say for 48 hours, actually it is not required. Most of these children can be managed only with normal saline or hypertonic if required for the outburst. And after 48 hours, you start off with the enteral feeds. So these are the very few basic things which we adhere to. I do not have any experience with the cystonostomy in the young children. I am being very aggressive in doing decompressives if my ICP remains refractory to management with this hypertonic saline and external ventricular drainage. And we don't open the dura in very young children, less than 1 year of age. We just take out the bone flap. We don't do any durotomy in less than 1 year of age. That's it. Cystonostomy, I really need to see it further, the results, the surgical videos being coming up to be able to convince myself if I can really do it in the tight brains, because that remains the apprehension of most of the neurosurgeons all over the world, because you need special skills to do it. IP Cherian cannot be present all over the world to demonstrate. However, he has given a very strong and a very positive message to the world and explained it scientifically also. So congratulations, but I still very, very decent outcome. In fact, better than any of the centers in the world with protocolized management of these children. And sometime next year, we will come up with discrete guidelines in the management of these children once the results of ADAPT study they actually come out. A word of caution is that these you need to tailor-made your guidelines as per your local situations. So not all centers in the world may not have access to ICP monitoring, which is quite expensive, I would say. So one can actually tide away by doing some external ventricular drainage in such children. That's my take on management of these children. I
You're on mute there. You're on mute still, Mike. There you go.
Yeah, see, what Deepak said is absolutely right. I would agree with Deepak on a lot of things. In fact, as he said, you don't require rocket science to save these children. And of course, the results in children are much better than in adults. That's something we have seen too. But the theory that I just highlighted, this is what we believed in, and I understand that sometimes, yes, I mean, I would wish that I could give, I mean, retrospectively, sometimes I have wished that maybe a hypertonic saline would have helped, or even sometimes mannitol would have helped. But having said that, now decompressive hemicranectomy we have done for quite a lot of children. I mean, when I was in Vellore, as well as when I was in a consultant in Kerala, and even in Nepal, we have done a lot of decompressive hemicranectomy for children, and they do very well, and they come back for the cranioplasty as well. But what I have seen is the loss of brain, which means the atrophy, is much more in decompressive hemicranectomy compared to the cystostomy that we see. So this is something I would like to put it into Deepak's notice. And the other thing, as he said, the trials and the data coming out. And yes, we completely agree to that because this is evidence-based medicine. Another thing is, you know, as he rightly pointed out, during times of trauma, you really don't get a surgeon with vascular experience, or I mean, to operate during that time. So if you have to open the cisterns, compared to just a decompressive hemicranectomy, this is going to be extremely difficult. So you're talking about a very easy surgery which gives reasonable results in children, and extremely difficult surgery which gives a little bit more better results. In children, we're not talking about a radical difference. In adults, yes, I would tell that I would not accept decompressive hemicranectomy because the difference in results are radical. But I have seen, it's not that I have not seen decompressive hemicranectomy children doing pretty well. I mean, I don't disagree with Deepak there. So, yes, it is what you have to sacrifice is a lot of, I mean, the cons for this surgery would be a lot of equipment, a lot of expertise and learning curve. And the advantage would be a slightly better outcome in terms of brain atrophy. I would like to ask Deepak as to what he thinks about this.
I think it's an unending discussion, I would say, regarding cystostomy versus decompressives. I must accept that I'm not very comfortable with the decompressive cranectomy per se, and because now over a period of time I've started observing sequelae of decompressive cranectomy both in the adult and the children. So I do try to avoid it as much as possible. And as I said, believe me, with very simple means of putting in giving first line therapy to these children, external ventricular drainage, head and elevation, no neck kinks, avoiding doing tracheal suction, endotracheal tube suction with proper anesthesia or xylocaine spray locally. If you are able to tide away the first 3 to 4 days, lots and lot of these children, they can be avoided, either the decompressive or cystostomy. So believe me, medical management holds a very strong role, in the management of these children, because lots and lots of these children, you can avoid doing surgeries. However, till the time people learn the tricks of cystinostomy, I would not vouch for it. I would say it is better to be as simple in acute trauma settings, especially when the residents are operating without any adequate training, as possible, because the TBI management in acute care setting is all a kind of a game of being simple and being quick.
Thank you, Deepak. I would like to show a single slide right now. So I have 5 minutes left. So I would like to show just a single slide.
You have more than 5 minutes.
Can I'm sharing the screen, John.
Okay. Not yet.
Yes, I'm sharing right now.
Not yet. Okay. Okay.
Can you see that slide?
Yes.
Yes. Oh.
Proposed mechanism, CAT scan.
Right. So this is the child who came to us with a motor score of 5. I don't really remember what his other scores was. Motor score was 5 when he came to the casualty. When he came to the emergency, his motor score was 5. And then we were doing rounds, and then we were finishing rounds, and then they suddenly called us. They suddenly called us saying that the motor score has dropped to 2. He's just decelerating. So we went into the casualty. With this scan, I had to take him into the OT. So if you look at this scan, it's not so bad actually. The only thing you would find is that hypodensity in this basal region. In this basal region, once you look at the cisterns are very well seen. There is no evidence of widening of this CP angle cistern or any subfalcine herniation or truncation of brainstem. So I was puzzled as to what was the reason why this child started decerebrating. Now this is the immediate post-op scan, and you see the reason. I don't know how the scan looked when he was taken into theater, because we had to take him into theater with that initial scan. But you can see here there is absolutely no cisterns seen. Nothing seen. If you see the basal region, there is nothing seen. And you can see this hypodensity is extended to the other side also. So we took him into theater. The dura was stone tense. So we opened the dura and the base, and then you had brain coming out like that. And then we got into the cisterns. After some time, the CSF was drained out. The brain became much more lax. We put in a drain. You can see this drain into the prepondine cistern, and we waited for some time. The brain was not coming up, so we put the bone flap back there, and then we came out. So this is how the immediate post-op scan looked like. It's not very good. So, but as Deepak says, once this patient survives, they do pretty well. And this is at the end of 6 weeks, and that's the guy at the end of 6 weeks. I have another video showing this guy coming for a follow-up. He's talking, walking, and even going to school right now. So that's just one. I mean, it's just a one-off slide showing that we, the decompressive hemic. We did not do the decompressive hemic. This was pretty bad because this was drastic. Because this patient came in like that, and this is how he was, just prior to surgery, and this is immediately after surgery. So I wanted to know whether Deepak has seen cases where you have a sudden deterioration. I'm taking off the screen sharing. Am I off the screen sharing now?
Yes, you are.
So I wanted to see what is his opinion on cases where these children come and they suddenly deteriorate, even when you are conservatively managing. And you had experiences with cases where they suddenly deteriorate, and when you take them to theater, you find this massively edematous brain.
Oh yes, unusual, and there comes the importance of monitoring these children, and that's why I said for me, I am one of the strong believers of ICP monitoring. I do keep intraparenchymal and EVT both in place for my children, and it really guides me. Number one. Number two, the patient which you showed, the first scan actually was not good. I would say the scan was bad because this child had got large frontotemporal contusions on the right side. And I believe that's what I talk about. Contused brain is a very, very dangerous brain because they can swell anytime. These children of these children and even the adults, they have got so-called subclinical seizures, and
So
this
we
phenomenon is called
opened the base, and then you had brain coming out like that. And then we got into the cisterns. After some time, the caesar was drained out.
Kumar is fine, and the previous video has been.
Much more lax.
Natararan, you have to turn your computer.
One down cistern.
Hello, Natararan, you have to mute, please.
Waited for some time.
Can
Brain was
you
not
mute
coming out.
your screen?
Bone flat back there, and then we
You
came
can
up.
mute.
So this is how the post-op scan look like. It's not very good. So, but as Deepak says, once this patient survives,
Natararan, you have to mute, please.
this is at the end of 6 weeks.
Okay.
Dr.
And that's
Muthukumar,
the
can you just
at the end of 6 weeks, I have another video. Showing this guy coming for a follow-up. He's
don't
talking,
believe it.
walking,
Okay.
even in school right now.
I
So
hate to turn.
that's just one. I mean, it's just a one-off
Natararan, can you hear
slide
us okay?
showing that we,
Can
the decompression.
you mute, please? You're playing the video. We hear it.
This was
My side?
drastic because this patient came in
Someone
like
playing
that,
the video.
and this is
Okay.
how he was.
Okay, well,
Just
okay, very good.
Okay,
Okay,
perfect.
very good. Okay.
What I was telling you was, I mean, the contused brain is a dead brain, and these are the biggest culprits, I would say. If in the burst temporal lobes or the burst frontal lobes, they usually have got associated acute subdural hematomas, and this phenomena of osmotic gradients exist. And these are the brains, they swell very, very rapidly within 6 hours, or in fact much more earlier than them. So my philosophy is completely different. I believe in taking out the contused or the dead brain. It causes no harm because that brain is already damaged. And along with that, if I am comfortable and if I can do, I will definitely open the cisterns within my acceptable surgical limitations, and if some resident is there. So this phenomena of acute deterioration in patients of severe traumatic brain injury does happen, does exist, and at some times these are causes are purely medical, and yes, these patients do throw seizures which are subclinical, they are not picked up, and that is one of the mechanisms of rapid deterioration.
thank you, Deepak. Yeah, I mean, that is what I would like to have talked to. Tomorrow I'll be talking on the mechanisms of cystonostomy again, along with the cooling and cleaning functions as well. Hello? Can you hear me?
Yes.
Yes, I can hear you.
Yes, we can hear you.
Tomorrow I'll be talking on the CSF shift edema as well as the cooling and cleaning functions, which are very important in the perspective of cystonostomy. It's not very good. So, as Deepak says, once this patient survives,
You have to mute, please. Okay.
at the end of
Someone's playing a recording of the video.
Yeah.
Natararan, please. Okay. Okay. There you go. Okay. Okay. Sorry about that.
All right then. Thank you.
You're playing the video, but hear it.
This was drastic because this patient came in like that, and this is how he was.
Natararan, can you hear? Can you hear? Okay.
Okay, very good. Okay,
Okay, very good. Let me try to.
So, what I was telling you was, I mean, the contused brain is a dead brain, And these are the biggest culprits.
Okay. Okay, Ike. Okay, you need to unmute, Ike. Unmute.
I'll just.
Natanaran, can you hear me? Okay. Okay, well said, Ike. You can unmute now.
I can hear you, John. I can hear you.
Okay, good. Okay, I just have a question, partly from a non-neurosurgeon. Why, you mentioned that results with children is better than adults with cystonostomy, and why is that, do you think?
Well, I believe that this is because of the plasticity of the brain, because children are able to take a much more bad abuse to the brain and then come out completely okay compared to an adult. So I have seen a lot of children where I did not have much hope after decompressive or cystonostomy, but after 6 months I was amazed to see them that they have done much better. And I'm sure Deepak also, being in a place where he sees a lot of head injuries, you would have seen this. You know, in Nepal we get a lot of pediatric head injuries because they usually fall off heights, and because we have a lot of hilly regions around, so they fall off from the heights, and we have a lot of traffic accidents. So most of these would be just fractures and depressed fractures and things, but we have a lot of these head injuries also, as Gaurav would know, that we have a lot of these head injuries which sometimes require cystonostomy. So I'm sure Deepak also would have seen that the amount of insult that a pediatric brain can take is much more, and they come out pretty okay, and they come out almost normal. So, and that's why I mean it's the same with us, that the mortality and morbidity is much better in terms of pediatric head injuries compared to adult head injuries.
We are joined by Professor N. Muthukumar. He is a professor of neurosurgery in Madurai Medical College in Madurai. Professor Muthukumar, welcome to this forum. We can see you well. I hope you can hear us very well. We are having a discussion. We are having a discussion, sir, on pediatric traumatic brain injury, and IP just finished his talk on them. And right now we are just discussing why the outcome is better in the children as compared to the adults. So it's just a didactic thing going on. What are your thoughts on that?
I just a couple of minutes I joined the discussion, so I don't think it will be appropriate for me to just jump in with the suggestion. So I should have listened to at least a part of the lecture. So maybe we can proceed with your presentation.
Okay.
All right. But may I ask you how differently how you manage your children? Do you do ICP monitoring in your children, or do you give mannitol, hypertonic saline to your children? Do you have any protocols in your setup, sir?
As of now, we don't have any fixed protocol, but we generally are not great enthusiasts of hypertonic saline. I am still a mannitol man, and we do not routinely use ICP monitoring in our setup, because mostly not because we don't believe in that, but because of the financial constraints that plague any developing country like us. So that's the main reason for which we don't use ICP.
Thank you. We are joined by Dr. S. Dwarkanath. He is a professor of neurosurgery in Nimhans, which is a very high volume trauma center in southern part of India. Welcome, Dwarkanath. Dwarka, can you hear us? You have to unmute. We cannot hear you, Dwarka. We cannot hear you.
Well, we cannot. I don't think he's muted. I think it's a problem with the audio.
The audio is not coming, Dwarka.
Yeah. Well, yeah, he is. Okay, yeah. Okay, go ahead. Talk. You can talk now. We cannot hear you. Okay. Okay, I think.
One last question. We have some time. So one last question I may ask to Professor Muthukumar.
Sure.
How often does he get a CT scan in children with minor head injury? I mean, what are the children he does not advise doing a CT scan?
See, I think way back about 10 years ago, there was a World Health Organization subcommittee that provided guidelines for CT scan in head injury. That was not specifically meant for children, but then I think overall for all children, anything less than GCS 14 or other criteria which includes the presence of any loss of consciousness, ENT bleeding, seizures, or severe vomiting, severe headache, when there's a skull fracture, I mean, brain radiograph shows a skull fracture, all these children get CT scan. But the unique situation in our place is that now people are so much concerned about the consequences of head injury that many a time, even when we feel that the child might not be require a CT, if the parents would, for their own for personal reasons, for their psychological satisfaction, would like to have a CT scan done. That's something that is you have to concede to their anxieties. Indeed, that's some sort of anxiety on the part of the parent that the child might have some long-term consequences of head injury. So many of them, in fact, they do. By the time they reach the neurosurgeon, they have already got a CT scan. It's really surprising. And my state of Tamil Nadu, CT scan centers are available in all district hospitals, and any patient anywhere in Tamil Nadu can access a CT facility within 45 minutes or on average 30 minutes. So
yeah, nowadays the night guidelines. Yeah. So nowadays we do have nice guidelines which have been revised for the indications of CT scan. However, one can always do a low dose CT scan, and in case you've got facilities available, some centers people like to do MRI also in children to get away from the radiation risk to the children. But the NICE guidelines are very apt enough in fact, most of the guidelines you've actually enumerated in just a few seconds back on when to do CT scan and when not to do CT scan. Thank you, Professor Muthu Kumar. Dwarka, can you hear us? I mean, hello, welcome to the group, Dwarka.
Okay, I think we need to wrap this presentation up. I agree. Thank you very much. I'm sure we could continue for another hour, but let's wrap this up before we prepare for the next talk. So thank you, everyone, for coming, and we'll sign off now. Thank you.
Thank you.
Thank you very much.
Okay, why don't we stop now, because we got to straighten out the sound of Dr. Srinivas. Hello, Doc. How you doing? Drakana, you probably can't hear me. We got to work on your audio. It's not working. Can you hear me okay? Yeah, your audio is not working. We need to work on it. Can you talk a little bit? Can you talk? We can't hear you. We can't hear you. So you need to, you may need to reboot your computer and come back. Yeah, we can't hear. Or fiddle with the controls if you know how to do it. I don't know if you know how to do it. Yeah, we can't hear you. Can you hear me? Yes or no? I can't hear you. Can't hear you. Yeah, just not yet. Can't hear. Give me a thumbs up if you can hear me. Can you hear me? Oh, I guess you can. Okay. Yeah, let's work on this. Get it going. I think it's reboot.
I've asked him to sign out and sign in again.
Yeah, he needs to reboot.
Yeah.
That takes away our most problem. Do you have his phone number?
I just called him.
Oh,
I just called him.
Yeah, reboot. Reboot.
Dwarka.
Reboot. They seem to be getting the message. Reboot. The old-fashioned written message. Yeah, okay.
No.
Yeah. Rebooting usually takes care of most problems. Usually.
In case Dwarkanath is not able to reboot, who is the next speaker online, John?
Yeah, sure. We'll see. Get back in.
Professor Mithu Kumar is speaking at what time?
Tomorrow evening.
8 minutes. Oh, I'm sorry. You're speaking not today, right, Doc?
No, I am speaking on Sunday evening 4 p.m.
Sunday, yeah.
And
Sunday.
any case, I am in the hospital and my laptop is running out of charge, so I don't have the charger here. So I need to really log out and go back home and charge. Okay, I'll join you later.
Okay. Thank you very much for joining, Professor. We really
I'll join you shortly. I am sure around 1 o'clock or 2 o'clock there is a talk. Is it so?
Yes.
Yeah, I'll
So
join you there at that time. Okay.
We are online for next 2 days.
Okay, fine. I'll come and
You
join.
can join anytime.
Shall I just click on the same link?
Yes.
Okay. Thank you, Deepak. Thank you, Jung. I'll join you in a couple of hours again. Thank you.
Okay.
Bye.
Okay. Very good. Okay. Skeleton crew now. Yeah, the audio is a common thing, but usually when you reboot, because a lot of people use Skype and the computer thinks that Skype is.
उसका earpiece हटा दे. Just talk direct from the laptop. Okay.
That's a common discussion, huh, with the cystonostomy in conferences. It's very controversial, right? You're muted, Deepak. I don't know if you're talking to me or.
I said I'm talking to you, John. Yeah,
okay.
It's correct.
Yeah, it's a pretty controversial subject at conferences.
Yeah, it's very controversial. Yeah, it's still not accepted by the majority of neurosurgeons. It's a lot of discussions and heated debates.
Yeah, it could take. That would be a good one for 2 hours, I think, with a bunch of neurosurgeons, not just 1 hour.
No, 2 hours is too less.
Really?
Yeah.
Well, where is it done mostly? Is a lot of it done in India, or is there any place where it's done more than others?
No, cystonostomy, we have been doing it for other conditions like subarachnoid hemorrhage all over the world. Okay. Whenever we are looking on the aneurysms, we are doing it. But the only issue is people are very reserved on being able to reach the basis of the brain in tight brains, because head injuries, the brains are very, very tight and swollen brains. So it is not so easy as is talked about to reach the bases and open the cisterns and drain the CSF. It's not so easy technically. So I always advocate and tell people to be very safe and quick in head injuries to give a good outcome, rather than being adventurous.
It takes a lot of training to get the right approach and get in there.
It's not feasible actually to do it in the tight brains. It's not feasible actually.
Yeah. Okay. Let me send the doctor another email. Sometimes people don't know how you get back in. Okay.
Yeah. Dwarkanath.
Yeah, his audio worked fine the other day. We did an orientation.
No, he's smart. He will be able to do it. Don't worry.
Oh.
John, you should be providing some online coffee to the people who are sitting in the
Yeah,
hall.
I want to ask the people in the hospital, how's the coffee in the cafeteria? Is there a good cafeteria there in the hospital?
Yeah, I will invite you sometime to India, and then we'll see.
Okay, let's see. Hello, can you hear me?
Yeah. Can you hear me now?
Yeah,
Yes.
finally. Yeah, the
Very
rebooting is a miracle.
Oh, good.
Dwarka, you are very loud. You are causing me some issues in my tympanic membrane. No, I'm just joking.
Good. Nice to see you.
Welcome.
Okay.
Okay. So you're pretty sure on the screen share. You want to go over it real quick, or you remember it? Okay.
Okay.
You want to practice it? We haven't really started yet.
Okay. I think yeah.
You want to do it real quick? Yeah, very good. Right, you got it. You got it. Perfect. Perfect.
So now you can hear me, right?
Yeah, I can see it fine.
Yeah. So
Okay,
can I use?
I think we got it a minute or two, right? Deepak, do we have a minute or two?
Can I use my earphone or something?
It's not required. Actually, you are quite audible, Dwarka.
Oh, fine.
Just increase the slide size, just so that it's visible better.
Now?
Yeah,
Okay.
Can you change the slide to make sure you can change? Okay. Click on the next slide on the left column.
Yeah, I'm clicking on the next slide.
You're not it's not moving, so you need to click manually on the left column.
On the left side of the panel.
The left side of the screen. Are you clicking on the left column? Yeah, we got it. History.
Okay, it works. It works.
Okay.
Very good.
Achha, okay. You can't make it a slideshow or something.
Okay, let me introduce you. So get off the screen share. Click on the green arrow again to get off it. So I can introduce you, and then you can go to the screen share after that. Okay. Okay. Here we're gonna start right now. Okay. Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from sunny, dark Miami. This is Dr. John Bennett of Neurosurgical TV in the continuing collaboration with Deepak Gupta of the Department of Neurosurgery at the AIIMS Hospital in New Delhi on a conference on pediatric neurosurgery. And today we have the pleasure of having Dwarkanath Srinivas, a pediatric neurosurgeon from India, who was nice enough to volunteer his time. Let me introduce the guest first before turning it over to Doc. Hello, Dr. Gupta.
Hello, John. Thank you very much, and Dr. Dwarkanath, thank you very much for joining this platform. And I'm very excited to join, and I look forward to your talk.
Thank you, Deepak.
Okay, very good, Doc. It's all yours.
Okay, so I go back to the screen sharing.
Can you please introduce yourself? Tell you where you work, who you are, etc.
Okay, I am Dr. Dwarkanath. I work presently as additional professor at Neurosurgery at NIMHANS, Bangalore. This is one of the few centers of national importance by the Government of India. I did my neurosurgical training in AIMS, New Delhi, along with Deepak. So that's how we've been good friends now for more than 20 years. So nice seeing you again, and I hope you enjoy my talk.
Very good. Welcome.
Okay. So do I start my talk now?
Yes, please.
Okay. So what I'll be doing is I'll be talking on a syndromic craniosynostosis. So this is an overview on what are the common craniosynostosis.
You're not on the screen share yet. Not yet. No.
Okay.
There you go. There you go. Perfect.
Yeah. It's fine now?
Yes.
Yeah. Okay.
Okay, are you there?
Just a minute.
Nope, you just fell off again, the screen share again.
Yeah. So what I'll be doing is I'll be talking.
It's still not on. It's still not on. I'm sorry, Doc. It's still not on.
Okay.
Still not on.
So we do have a few teething problems starting.
It's not. The screen share is not on yet. Not yet.
Dwarka, not the slideshow. You have to just screen share and run the slides in a presentation, not the full slides, please.
Okay. Now?
No. Click on the green button and screen share your desktop.
Yeah. Now we are getting it?
Not yet. Not yet. No.
You open the presentation. You open the presentation like a normal PowerPoint presentation on your desktop. Don't make it too big size, and then you screen share the desktop.
No, it's open. The presentation is open.
Yeah, but not for us. There
Yes,
you go.
now-
There you go. You had it. Oh, you fell off again. You made it too. You made it big. Don't make it big.
Make it small.
Yeah, you make it. Yeah, you can't expand it. You got to keep. Unfortunately, that's a shortcoming of this program. So open up your PowerPoint. Don't make it big.
Yeah. Now is it fine?
Not yet. Not yet. Not yet. Not yet. Not
Now
yet.
can you see it?
No, not yet. Not yet. It's okay. Keep trying. Try something else. Okay. Okay. Yeah. Minimize the Hangout. Go to your desktop. Open it. Then come back to the Hangout.
Yeah.
Okay.
Yes.
Yeah,
Perfect.
it's on. It's there. Okay. Okay. Very good.
So what I'll be doing is I'll be talking on syndromic craniosynostosis, and what I'll be doing is I'll just show you a few common syndromes and then discuss how to manage it surgically. Craniosynostosis, if you actually go back into ancient history, you will see lots of funny-looking characters, and you start wondering whether they really had craniosynostosis or were their heads remodeled like that. And there has been a practice of wrapping the skulls of infants and altering the head shape to be more egg-like than rounded. And it has been used by many cultures to produce a cosmetically pleasing effect. But of course, we cannot say all craniosynostosis are cosmetically pleasing, otherwise they won't come to us for treatment. So the relation was first established in 1791, that's almost 200 years old, where the relationship between the suture growth and the cranial shape was first noted by Sommering. And an important breakthrough came by Bischoff in 1851, described how the skull growth is restricted to a plane perpendicular to the affected suture and is enhanced in a plane parallel to it. And there have been multiple procedures going on over a period of time, but rightly Tessier has been called the father of modern craniofacial surgery because the first successful and the good results consistently came when Tessier started operating on these patients. And craniosynostosis needs to be differentiated from cranial dysmorphia. And cranial synostosis is one of the several causes of cranial dysmorphia. The Bischoff's law, like I mentioned, says that the sutures allow growth perpendicular to them. And whenever a suture fuses prematurely, the growth occurs perpendicular to the fused sutures and allows compensatory growth at the open sutures. And this results in an abnormal skull shape. Just before I go into the craniosynostosis, I'd just like to mention that the brain development at term, the child has nearly 40% or approximately that amount of his brain volume, which increases to 80% by 3 years, and the child brain achieves complete maturity at around 12 years. So you see the brain growth continues to happen after birth, and this plays an important role in the molding and cosmesis of craniosynostosis. So the growth is in a cranial pattern, and like I mentioned, the facial growth is not consistent throughout. While the initial rapid cavalier growth occurs during infancy, the orbital and mid-facial growth occurs in the first decade, mandibular growth in adolescence, and over the first year of life it triples in volume and reaches the adult. And these are the major sutures: the sagittal, the coronal suture, the anterior coronal, the topics, etc. So from time the anterolateral fontanel first followed the late last to around 4 years. While the etiology is unknown, there are multiple factors like white maternal transmission, injection, few drugs like chlordiazepoxide, nitrofurantoin, maternal occupations, treatment, and there have been multiple gene mutations which have been described syndromic and non-cases, which I'll come to it, and there have been multiple secondary causes. The varieties are common. Comparing males and the metopics, female, and usually disorder. The shape which they have assumes and I'll just go syndrome is a combination of brachycephaly, tachycephaly, facial dysostosis. Various and which show description of which, for example, scapocephaly towards
Whoop. Breaking the action. Okay, we lost him, Deepak. He'll come back on.
Yeah, I see. I know that's a problem of doing it from the hospital.
Yeah, we could always repeat this when he has a cable connection. When I had to hang out with him, the Wi-Fi was good; it was working fine, but Wi-Fi is inconsistent.
But who's the next speaker, John?
The next speaker is Surash Sankla.
Okay.
Yeah.
Why don't you just send him an email quickly? Okay.
Okay. Let's. I guess we can continue. We can edit this out.
Okay. In a
okay, Doc, let's try it. It seemed to work. The Wi-Fi seemed to work the other day. You want to continue?
Pardon. Now is it? Now am I audible?
Yeah, it seems okay now, but we'll see.
Yeah.
Well, and we'll edit this out. We'll edit this out.
Yeah, this is an office Wi-Fi, so there is going to be some fluctuations. I cannot help it.
Yeah. So you don't have cable there in the office, right?
Cable also doesn't work very well. So the Wi-Fi is quite fast.
You do have cable there?
No.
Oh,
the office is Wi-Fi completely. Yeah.
Yeah, the Wi-Fi seemed to work the other day.
Is it working now?
Yeah, it is, but you can never tell. It's inconsistent.
Please continue with your talk.
Yeah.
Yeah, once you finish it, and we can always do this another time when you have a cable, and just basically erase this. But let's
Deepak, can you hear me now? Yeah. So the signaling molecules have been described like the FGFR1 and FGF in Apers, Cruzen's, Muenke's, and all. Twist syndrome in Hattrick Cotson's.
Screen share.
X2 in
you want to screen share, right? You want to screen share? You're not screen sharing.
Is it?
Okay. No, it's not screen sharing yet. Not yet.
Yeah.
No, we don't see your presentation.
Not yet.
Is it okay now?
Not
No.
yet. Not yet.
Open your presentation on desktop and screen share that.
Oh, it's open.
There we go.
Okay,
There we
now
go.
it's
There
no,
we go.
it's
Well, it went off now. Okay, it looks like it's
okay.
getting there. That's the problem with the Wi-Fi. Okay. Yes. Okay, we can see it. Okay.
Okay. So the various disorders being described are the FGFR1, the TWIST1 genes, the MSX2 in Boston types, the FNB1 in the craniofrontonasal syndrome. So these are all the various signaling molecules which have been described, and probably the importance would be in translational approaches in which you can use gene-based therapy for management of these syndromes. But genetic non-syndromic also have been found genetic variations like the FGR mutations in the coronal sutures, but these are very small and by far account for less than 2-3% of mutations. So while non-syndromic do have mutations, by far the most common causes of mutations are found in the syndromic craniosynostosis. Coming to the major syndromic craniosynostosis, the first would be the Cruzens, which is by far the most common of the syndromic craniosynostosis. It has mutations in the FGFR2 growth receptor and has an autosomal dominant inheritance pattern. The main skull anomalies described have been the brachycephaly, the scavocephaly, trigonocephaly, and the children have a normal intellect. But apart from that, the other facial anomalies have been described in Cruzens. This is one of the Cruzens which are operated where you can see the various anomalies where there is an exorbitism, that is the shortening of the orbit which causes the eyes to be proptosed. That is mid-face hypoplasia, which causes the mid-face to be gone back. There's an anterior open bite, hypertelorism, beaked nose, and there is no commonly reported limb anomalies in Cruzens. I'll be coming to when we compare it with APERTs. But the child importantly has a normal intelligence, and though they could also have associated features like conductive hearing deficits, strabismus, and hydrocephalus. Like I mentioned, the intracranial anomalies also which could be associated with hydrocephalus carry one malformation, hyoid herniation. And it's important to remember that because of all these intracranial anomalies, Cruzens have a higher risk of elevated intracranial pressure than other forms of syndromic craniosynostosis. While in one study they have demonstrated almost a 65% incidence of elevated intracranial pressure. Coming to the APERTs, APERT often has been described as Cruzens with hand involvement. While it holds to a certain extent, it's not exactly true. The mutations are in the FGFR2. It also has an autosomal dominant inheritance pattern, but it's much rarer. In the comparison between Cruzens and APERTs, the Cruzens there's an earlier closure of the lambdoid and sagittal sutures, 6 months versus 51 months, and sagittal sutures 21 months versus 60 months. And the incidence of Chiari-1 malformation is much higher in Cruzens than in APERT syndrome. The clinical features of APERTs are taribrachycephaly, the most common being the bicoronal synostosis. They have a very characteristic large anterior fontanelle. Like this is the anterior fontanelle which is characteristically open and wide. They have a bitemporal widening with occipital flattening, and they frequently have a much severe mid-face hypoplasia than Cruzens patients. But the most pathognomonic feature of APERT syndrome has been the fusion of the second, third, and the fourth fingers. This is classically seen over here where the fingers are fused. The thumb might be free, but it is broad and deviates radially. In the feet, it usually involves the second, third, and the fourth digits. Like these are the feet. You can see the toes are fused, and they're so severe that they usually require surgical correction. The other clinical features are that the child has a varying intellect, but 50% have intellectual anomalies. They have cervical vertebral anomalies, but hydrocephalus is rare. Acne vulgaris characteristically develops during adolescence in over 70% of the patients, and characteristic nasal deformities resulting in a parrot-beak deformity occurs in syndromic craniosynostosis. While some studies have described that raised ICP occurs in 83% of the patients while 50% occur in the first year of life. There have been some series which describe a far lesser incidence of raised ICP in Aper syndrome. The third most common syndrome would be the Pfeiffer syndrome. This is one of the Pfeiffers which we had operated, which involves mutations again in the FGFR2 gene, and the inheritance is autosomal dominant. There have been various grades of Pfeiffer syndrome described by Cohen, who's classified them into three parts. One would be the type 1, which is the classical Pfeiffer syndrome, which is seen in 61%. The type 2 is more severe and associated with the Klibat schedule, which is the cloverleaf skull, which is seen in 25%. And type 3, which is the most commonly affected, which is the most severely affected, seen in around 14% of the patients. The clinical features ranges in severity from mild to severe, ranges from taribrachycephaly to midface hypophasia to exorbitism to hypertelorism and class 3 malocclusion, strabismus and downslanting palpable fissures. These are the patients. You can see the downslanting palpable fissures over here. The exorbitism, you can see the eye, the brachycephaly, which can be easily made out. There are varying soft tissue anomalies like broad thumbs, broad great toes. There is no fusion. Again, it's important to remember that all these three syndromes, intelligence is usually normal, but they do have associated systemic symptoms like oral atresia and conductive hearing loss in almost 80% of the patients. Hydrocephalus is seen in 70%, and Carey malformation is also seen in 80% of the patients. The other syndromes which are much rarer are Sathry-Kotzen syndrome, which has an autosomal dominant with mutations in the twist1 gene. And the clinical features are a heterologous pattern of craniosynostosis, again a craniosynostosis with taribrachycephaly. They have a low frontal hairline, eyelid ptosis, facial asymmetry, ear deformities with a characteristic prominent crus helicis, and minority only have a hearing loss. Midface hypoplasia is not a common feature of Sathry-Kotzen syndrome. Moehnke syndrome is one which is the first report of a genetic mutation rather than a phenotypic description. The clinical features include craniosynostosis of the coronal sutures with significant variability in the presentation of craniosynostosis. Again, bicoronal craniosynostosis is the most common presentation for both sexes. And hearing loss is common. There's a developmental delay, and midface hypoplasia is not common. Point to remember in Moehnke syndrome is that most of these patients, after they have undergone childhood correction of craniosynostosis, frequently require reoperations for either elevated ICP or failure of the repair. The reason is not known, but Moehnke syndrome characteristically have a higher rate of failure in craniosynostosis surgery than any other syndrome. Carpenter syndromes are some of the more severe types. The autosomal recessive, there is syndactyly of the feet. The sagittal lambdoid sutures close first and results in a classic cloverleaf skull. So these are the common syndromes, and how do we go about clinically evaluating them? First, of course, is a clinical, detailed clinical history. A family history is very important. You should ask for abnormal head shapes or multiple systemic problems. Clinical examinations include a complete systemic examination, apart from the head, including rule out deafness, cardiac anomalies, etc. Look for the limb abnormalities. Most importantly, you have to look for raised ICP, which complicates almost 1/3 to 70% of the cases. And some centers have recommended ICP monitoring before surgery. The causes of raised ICP could be multiple, either due to abnormal venous drainage, or hydrocephalus, or respiratory obstructions, or Carey malformations. Hydrocephalus is seen in around 4 to 18% of the patients, usually a communicating hydrocephalus, and the causes either could be cerebral maldevelopment with subsequent obstructions, abnormal circulations, venous outflow obstructions, Carey malformations, and aqueductal stenosis. The respiratory anomalies are which usually manifest during sleep and are due to the midface malformations like maxillary hypoplasia, coronal stenosis, tonsillar hypertrophy, etc. And the management could either include use of nasal stents or nocturnal CPAP. But the most important was the child is added to the other difficulties encountered in these patients include abnormalities of palatal shape and movement, disordered dentition, dental malocclusion, nasogastric tube or gastrostomy, and vision. Vision is one of the most common, indications of urgent surgery, and you occur due to chronically raised ICP, which can lead to either papilledema and optic atrophy, or shallow orbits can lead to keratitis, or primary optic atrophy can occur from compression and traction of the optic nerve. And like I mentioned, these patients require early treatment. How do we go about investigating them? Of course, in the olden days, it used to be simple X-rays, which classically showed the harlequin eye. The copper beating of the skull is a good indicator of raised ICP, though it's not specific, but copper beating should be taken seriously and should be an indication for early surgery. Ultrasound, the transorbital ultrasound can be used to measure the optic nerve diameter. There have been studies which have measured nerve sheath diameters in patients with neurosurgery. It is low sensitivity for detection of raised elevated ICP when compared to that of fundoscopy. The most promising investigation, non-invasive, has been VEP, which measures the latency time of the average response. And if there is a delay in wave latency, it means that there is a abnormality which indicates some sort of axonal injury and correlates with raised interclavicular pressure. CT scan has been a standard for complete visualization of the skull and the cranial sutures. Detailed anatomy of the calvaria and the brain parenchyma. And MRI has been used to look at the brain structures, look at the improved definition of the intracranial soft tissue structures, look for chiari, and identify possible sites of respiratory obstruction in the midfield. An interesting thing is that ICP has been reported in many patients, and like I mentioned, Cruzen syndrome has the highest incidence of raised ICP, which occurs around 83%, while in oxycephaly it's around 58%, and APERS around 50%. While in other non-syndromic neurosurgeries, the incidence of raised ICP is very low, between around 7 to 15%. This is a study by Tuet et al. Which shows whether papilledema alone can be used. Even though it's a very specific indicator for raised ICP, it is not sensitive in younger children less than 8 years. But 100% of children above 8 years with elevated ICP had papilledema, and 22% of children less than 8 years who had elevated ICP had papilledema. So this is a probably important confounding factor in using papilledema as an indicator of raised ICP. So how do we manage this? The principles of management are very simple. One is we have to normalize the deviated appearance and growth and function of the skull, and keep the sutures open till the brain growth is complete. This is because one is a cosmetic problem. The second thing is this brain growth occurs throughout childhood. It's important to make sure that we leave it space for the brain growth. It is more simpler in non-syndromic, but in syndromic neurosurgery, management is much more common. And look for other intracranial anomalies, especially for chiari-1 malformations. And you have to have a discussion with the pairing, the options management, whether they would like management. It has to be a true and frank discussion with the parents, and it's a multidisciplinary effort. So let us not delude ourselves thinking that we alone can do it. We have to take help from multiple specialties, like a plastic surgeon, especially craniofacial surgeon, an ophthalmologist, otolaryngologist, orthodontist, as psychologists, social worker, genetics has to be done. So all these fields have to be taken, and indications for surgery include correction of cosmetic abnormality, early management of intracranial hypertension, optimize the brain growth, severe proptosis and impending corneal damage are important indications. And the other important indications would be the psychological effect on both the parents and the children and his friends. Because kids are very sensitive and they do not realize when they are teaching other kids about their deformities. So it's very important that the psychological outcome of the child, early surgery is done so the child returns to normal activity as soon as possible. In fact, we had one child with Cruzen's whose friends used to keep on trying to poke his eye. And it used to become such a big problem that the parents came and used to cry that we need this cosmetic effect to be very good so the child can go have a normal activity. These are some of the few indications for surgery. So when do we operate? If the child has elevated ICP, we need to do it immediately. But if the child has normal ICP, when to do it is a question. There are different points to discuss, and these are always debatable topics. But points to remember is that in earlier age, bone is more malleable and easier to remodel. But below 3 months, it's very soft, so decontouring becomes unstable, and there's high incidence of failure. While in greater than 1 year, the ability to cranial base to respond to internal forces diminish. And with increasing age, skull deformation increases in severity and permanency. So what we generally do is a Calvarian infant between 3 to 12 months is much more malleable, easier to shape and providing a better outcome. Generally, most centers prefer surgery between 6 to 12 months. And early surgeries prefer to prevent the further progression of deformity, possible complications associated with raised intracranial infection. So what are the basic principles? One is passive reshapement, like generalist removal of the bone, split craniectomy and morcellation. Active reshapement includes fronto-orbital advancement and cranial wall remodeling. And I will some of the important principles that use a stealth incision, which prevents parting of the hair along a straight line, looks more cosmetic. And I'll show you the diagrams later. Of course, the child needs a good preoperative evaluation, routine bloods. Syndromic includes rule-outs, obstructive apnea. What is the airway anatomy, which is important for using fiber optic intubations. Cure any sort of upper respiratory tract infection, especially in fusels and reverts. Look for congenital heart deficits. Once all this clear, the patient can be taken up for surgery. So, what are the current approaches nowadays? One is initial fronto-orbital and cranial wall remodeling has to be done in all patients. Previously, monoblock in that all the 3 procedures used to be done at the same time. Now it's not favored. Initially, we go in the fronto-orbital and cranial wall remodeling. Follow it up with a mid-phase advancement with or without distraction when the child is around 4 to 6 years. And when the child reaches further around 12 to 14 years, going for secondary orthognathic surgery to correct any dentation. So the goals include, like I mentioned, increase intracranial volume, decrease the ICP, improve the head shape. The most commonly used are the cranial wall remodeling with or without fronto-orbital advancement, while the other techniques used are cranial wall distraction and spring-assisted cranioplasty. So these are the steps in which you can see there is a frontal advancement, the orbital value is here, and the frontal orbit is also advanced. This is a hypertelorism correction, where a strip of bone is removed and then the 2 orbits are brought together, which corrects the hypertelorism. These are some of the cases which are done. This, of course, is not a craniosynostosis. This is not a syndromic, but I'll just mention the steps. You see the stealth incision over here, zigzag incision. This prevents parting of the hairline and straight line, so it's more cosmetic when a child grows up. The skin flap is elevated. Here the periosteal flap is elevated. I elevate the periosteal flap, but some people do not because they feel that there is more blood loss. I do not take it out a single flap. I do it as multiple flaps. Make a burr hole on either side of the superior sagittal sinus. Do a bilateral frontal craniotomy. Remove the 2 bone flaps on either side, and then go in for a central bony flap, bony segment elevation. So this is how the brain looks after the craniotomy. Frontal, complete bifrontal craniotomy. So once the craniotomy is done, our target is the supraorbital bone. When an orbital bandeau is taken out, we use fine drills, dental drills is preferred. Then we remove the orbital bandeau over here. And then this is the hypertelorism correction, which is strip of bone has been removed and the 2 orbits have been brought together. This reduces the intercanthal distance. And then we do the remodeling of the facial of the front orbital bandeau, make it more shapely, use probably resorbable plates over here, and then the orbital bandeau is replaced. This is advanced using metal plates or absorbable plates depending upon the affordability of the patients. And you see approximately around 1.5 to 2 centimeters of the frontal orbit is brought forward. And once it is done, rigid fixation is used to fix the bone flaps together. Nowadays, we are using rigid fixations only for the anterior to keep it in place, and these have been replaced by sutures. And then the suture, wound is sutured. These are some cases, the trigonocephaly which I have done. You can see the child after 4 or 5 years has got an excellent cosmetic results with the proptosis completely corrected. This is the same patient. This is a patient with Cousins disease, Cousins syndrome, operated. You can see again the proptosis has been corrected to a large extent. It was a large incision. Incision goes frequently posterior and the entire skin cap is taken. This is another Cousins. You can see the correction done over here. The proptosis has been corrected. This is one of a few unusual cases which we did in an adolescent girl around 16 years old. This is the oldest patient which we have done. We're not very sure because the bone is not very osteogenic at this age. But we had to do because she was developing these visual field constrictions due to raised IGP. And we did a fronto-orbital advancement along with cranial remodeling. And this is the cosmetic result we got in which the orbit is brought forward and the proptosis has corrected to a large extent. And the visual symptoms have remained constant for a period of time. The other procedures followed are posterior vault remodeling, in which FOA is contraindicated or not possible for certain reasons. The advantages of posterior cranial vault expansion is that it provides a larger volume increase per millimeter of advancement than anterior expansions. And many patients with teric brachycephaly have a posterior flattening, which is an ideal target for extracranial vault remodeling without fronto-orbital advancement. So posterior vault remodeling can be used exclusively if someone is not planning for a fronto-orbital advancement, because posterior vault remodeling provides for a higher volume increase. And of course, disadvantages are that there is increased blood loss. Limitations of fronto-orbital advancement, of course, is not possible. And an important thing is, especially in children, is that you have to remember that when the child sleeps, that there's a propensity for relapse because of the weight of the child's head goes onto the suture lines, onto the plates and screws. So there could be a higher rate of failure. This is a comparo of the two types. While the anterior is more complex, you have to be more precise and orbital advancement is possible. Posterior is that there is simplicity of anatomy. It is more forgiving to surgical errors. The hair covers the irregularities. Chiari 1 can be corrected, and there are fewer critical aesthetic structures. But like I mentioned, that there is a greater risk of failure because the child tends to, when the child is sleeping. But the great advantage is that FOA can be delayed and it can be used as an acute procedure. To get over this, where posterior vault, instead of posterior vault, a single stage where a distractor is placed and distraction osteogenesis is done, where the advantages include maintenance of bone vascularity, production of vascularized bone occurs, there's a gradual expansion over a period of time, it allows for greater advances to be achieved and maintained, especially in the mid-phase distraction. And it is advantageous in patients with severe tericephaly and occipital flattening due to posterior expansion. Of course, distractions are that we are living in a country where infection rates are probably slightly higher. Needs for second procedure for device removal. So, the problem of infection always remains, and device-related complications can occur, and the treatment time is prolonged. But one interesting benefit is that the Chiari ones have been shown to improve with posterior vault distraction and posterior vault remodeling. The other controversial things have been spring-assisted cranioplasty. We don't use it. The surgeon has no control over the distance or rates of advancement, and the technique remains somewhat controversial, and it has been used mainly in sagittal suture synostosis. Monoblock procedures used to be used in which the fronto-orbital advancement, the mid-phase advancement, used to be done in a single sitting, but this had significant surgical morbidity and there's high blood loss, high rate of infections, and it is not used at present. What is preferred is staged mid-phase advancement in which, like I mentioned, the cranial advancements are done initially, and when the child reaches around 4 to 7 years, the mid-phase is brought forward. The two methods have been used. One is a standard method in which a single stage. Second is like what I mentioned, a distractor is placed. The advantage of distraction is it allows a correction over a period of time, and it can be much higher rates of distraction can be done while compared to standard methods. But of course, the graft-driven, the instrument-related complications are higher. This is an important point in a country like ours. But it has a better efficacy and improved safety profile, and allows for expansion of soft tissue envelope with bony advancement, decreasing relapse from soft tissue contraction. Like I mentioned, it's less blood loss, shorter operative time, greater advancement, more than 2 centimeters compared with standard techniques which are around less than about 1 centimeter. Elimination of bone grafts, reduced infection risk immediately, but higher infection risk. Second procedure to remove worry device is an important complication, and it requires an external halo device, and some patients find it very inconvenient. However, distraction osteogenesis has significantly improved the results obtained for mid-phase advancement while minimizing the complications. Late intervention, like I mentioned, in adolescent patients has its own pitfalls because the adult cranium is less amenable for osteogenesis, and there's a higher risk of recurrent deformity, and surgical risk correction is more complex. In adolescents, probably it's just stage 3 where orthodontic surgery is done to correct the dental anomalies, and final facial contouring in which smoothing down irregularities, adding bone grafts or bone substitutes, and resuspending soft tissues is done in adolescent age groups. Every surgery has its own complications, including anesthesia-related complications, general complications. Specific include hypovolemic shock, which is an important factor, coagulopathic states, parenchymal injury, CSF leaks, intracranial hematomas, infections, all early complications. And long-term complications include wire and plate screw granulomas, temporalis muscle detachment and temporal hollowing, unsightly bumps and lumps, and if they recur, resurgery might be offered to the patient, should be offered to the patient, and to give a good cosmetic results overall. Our results are around 76 patients over 8 years. The most common have been the non-syndromic varieties, especially the plagiocephaly and brachycephaly. I think it's important to mention that in a country like India, many patients do not prefer surgery for minor and moderate forms of craniosynostosis because they feel that the child looks okay. In India, we generally tend to correct more complex and more obviously unsightly craniosynostosis. Multi-sutural, we have operated on 12 cases. And to conclude, I'd just like to summarize that craniosynostosis is an eminently correctable condition, but you need to have proper diagnosis and management decisions. The most important being a multidisciplinary management with proper counseling regarding the surgery, the outcomes, the possibility of multiple procedures. But once properly done, it has a very good and satisfactory outcomes. And when we did our study on our patients, we got a smile grading of almost 8 to 9. So I'd like to thank my two colleagues, Dr. Dhaval Shukla, my colleague in the Department of Neurosurgery, and me who do most of the plus the advanced. Thank you.
Okay, very good, doctor. Thank you very much for taking the time to present a clear presentation. Deepak, do you have any comments?
No, I just want to congratulate Dwarkanath for excellent presentation and covering almost anything and everything on syndromic craniosynostosis. Thank you, Dwarkanath, for a wonderful presentation. Thank you.
Thank you, Deepak. Thanks a lot.
Very good, doctor. This is the kind of, you get off the screen share, just click on the screen arrow to get off it. Yeah, this is the kind of education I think might be good for pediatricians and and outlying neurosurgeons. So, okay, I'd like to thank the doctor for taking the time, and I'll be sending you the link to this video.
Thank you, John. Thanks for the wonderful support you have provided us. And I think this whole thing would have been impossible without your help and guidance. And thanks for being patient with our internet in India, in Bangalore especially.
Okay, very good. Thank you.
Thank you, John. Thanks, Deepak.
Okay, bye-bye. Okay, very good. Okay, very good. Okay, we'll stop the edit.
And Dwarka, please stay online to ask questions to the next speakers. Be a part of the meeting.
Yeah, we can. We might be able to edit this, edit that out, or, you know, if you get to a good connection, we may be able to repeat this whenever. Okay. You know what I mean? Okay. If you can get to a cable connection, not now, maybe during the week or whenever. When you're in a good connection, we'll just repeat it, and we'll insert this in with the rest of the Hangouts.
Okay, sure.
So, okay. So the next talk doesn't start until, let's see, about 20 minutes. 15 minutes, right? Yeah, about 18 minutes. So we got a little break. Time for coffee.
Oh, sure.
I'm going to get coffee. I can fix my background there.
ठीक हो गया? चलो.
Hi, John. Do we have the next speaker online?
Yeah, not yet. We're waiting for him to come. Suresh. Yeah, that was very good quality. That was the first one that was. May have to repeat it.
John, Suresh Sankla has just sent me an email. He says he's ready on the computer. He needs a link. Can you just send him the link again?
Yeah, I sent him. Yeah, I sent him. Okay, I sent him once. Send it again. To his email. Ask him to his Gmail account. That's where I sent the link. There he is. Okay.
He's online.
Yep. Simon, have you met Deepak? You met Deepak, right?
Yes, I have. Hello.
Nice to meet you.
Hi, Simon. How are you?
Simon's in the operating room.
There's a big echo.
Hi.
Yeah, someone else has a program on. Okay. Suresh, can you hear me? If somebody has another program. I think Deepak, turn off all your other programs.
None of my program is open.
No, nothing's on? Yeah, somebody.
I think Suresh needs to be online. I think he's online, but
yeah. Suresh, can you hear me? Oh.
I'll just call him.
Sure, he'll come back. How you doing, dog?
Pretty good, thanks.
Huge echo.
You just getting home from work?
Yeah.
Okay. Okay, he's back. Hello, Suresh. Okay,
Hello. Welcome, Dr. Suresh.
Can you hear okay?
Yeah, Simon.
Yeah. Deepak here.
Okay,
Hello, sir.
Suresh.
How are you?
Oh, hi. Hi, Deepak.
How you doing?
Hi, Deepak. How's it?
Okay, do you remember how to screen share? Hello, Suresh. Can you hear me?
I think the network is breaking at his end.
Deepak.
Yes, we hear you well.
Okay,
Good.
fine. So, how's the picture quality? Sound, everything is okay?
Picture quality is okay. You just see whether you can screen share your presentation as told to you by John. I hope you can do it.
I can do that, yes. Of course.
Yeah, please do it. We have got 3 minutes to begin your talk.
Try it once. Let's see. Just practice it. Make sure you can do it.
Yeah. Is it showing up on your screen?
Not yet. You need to minimize the hangout. Open up the PowerPoint. And then come back into the hangout.
Yes, it is open.
It's open, but you're not sharing it. Go to the left side of the screen. Click on the arrow. And then pick the PowerPoint from the menu.
How is it now?
Yeah, I think there it is. Perfect.
Okay, perfect.
Okay. Okay, you ready to roll? Okay, just get off the screen share and introduce you. Yeah, where's that echo coming from?
Can you make it bigger? Can you make it slightly
echo is
bigger?
coming.
Yeah.
The echo is coming.
Shall I reduce my sound?
Shall I reduce my sound volume?
Yeah,
No, it's okay.
Suresh.
Yeah, Suresh.
You have to close all your programs
Close all your
Hangout,
programs other than the Hangout.
because we're getting an echo.
Because we're getting an echo.
Is it any better now?
Yeah,
Is it any better now? Yeah,
no, first you need to get off all the
first you need to get
programs
off all the programs
other than the Hangout.
other than the Hangout.
Turn down speakers.
Turn down speakers.
Yeah, turn down
That's
your
what I'm doing.
speakers.
That's what I'm doing.
I think your speakers may be close
Speakers
to your
may be
microphone.
close to your microphone.
Because
I'm done that.
I'm done
that's,
that.
hello,
Hello.
that's a little better,
That's a little better.
but still getting an echo.
Okay. I can do further down.
Okay, let's test. Okay,
Let's test. Okay.
Deepak, can you please mute?
Deepak, can
to
you
see if you still get the echo?
Echo.
Yeah.
Yes, just mute.
Just mute.
Deepak.
There's some echo.
Just mute. We're gonna. Okay, testing 1 2. Testing 1 2. It's coming from Deepak. It's coming from you. The
Mute.
echo. The echo disappeared when you mute. So, Deepak. So you must have something open.
Can you hear me now?
Yeah, we can hear you fine.
We can hear you fine.
Yeah, Deepak, we're getting an echo
Deepak,
from
we're
you.
getting an echo from you.
Because
There's nothing.
when we mute you,
When we mute you,
the echo goes away.
the echo goes away.
Now it's okay?
Hello. Yeah,
Hello.
okay.
Yeah.
No,
No.
hello.
No. Hello.
No, it's still there.
Okay.
No, it's still
Yeah,
there.
Deepak, you got something
Deepak,
open.
You got something open.
Everything is closed. There's nothing in my side. My cell phone is open, but it's on silent.
It could be, well, really.
Really?
Hello.
Hello.
Well, I'll mute.
Well, I'll mute.
Maybe it's me. Okay.
Maybe
let's
it's
mute.
me. Okay, let me
And
mute.
Simon, you talk. or
Simon,
something,
you
okay?
talk or something, okay?
Okay, I'm going to talk as a test.
Okay, I'm going to talk as a test.
There is an echo. Somebody's.
There is an echo. Somebody's.
Suresh is open, but he's.
Suresh is open.
I'm mute.
I'm mute.
Simon, I'm mute.
Who else is open?
No, you're
It's
not
open.
mute. We are hearing you, Dr. Suresh.
Is
Okay.
Yeah,
I think
yeah, I said-
we can begin, and everyone of us will mute subsequently, except for Suresh.
everybody needs to mute?
Everybody
except
needs to mute.
It's 1 o'clock now. I think we
It may
can
be
begin.
coming from Suresh.
Coming from Suresh.
Suresh, do you have anything
Suresh, do
open
you have
inside your
anything
Hangout?
open inside your Hangout?
I can't hear you.
Your
Okay,
side.
Deepak, can you mute again, Deepak?
Again, Deepak, please.
Sorry?
Can you
Okay.
mute, please?
Okay.
Testing,
I've done
1
that.
2. Testing 1 2. Testing 1 2. It's coming from you, Deepak, because when you mute, it goes away. But that's okay. That's okay. We'll start because you'll be muted anyways. Okay. Okay, Suresh, can you get off your PowerPoint so I can introduce you?
Okay.
Okay. Okay, you want to leave the PowerPoint, Suresh, so I can introduce you, please?
Okay. I can see my slide 1.
Yeah. You just click on. Okay. Well, I'll start it. Okay. We'll meet you after. Okay. Let me start. Okay.
Yeah.
Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. Well, good morning. This is Dr. John Bennett, televising from Miami. We're televising this event, Pediatric Neurosurgery, with collaboration with the Department of Neurosurgery, the AIIMC Hospital, and Deepak Gupta of the Department of Surgery. Today we have the pleasure of having Shiraz Sankla. He's going to be talking about posterior fossa medulloblastoma in children. But first, let me introduce the panelists. Hello, Deepak.
Hello. How are you? Thank you very much, Dr. Suresh, for joining us at this platform. And I'm very excited to listen to you and your thoughts on management of medulloblastoma.
Very good. Welcome, Deepak. And Simon?
Hello, everyone. My name is Simon Downs. I'm a medical student in Japan and a developmental psychologist. I'm looking forward to it. Thank you very much.
Love your background, Simon. Okay, Suresh, it's all yours.
Thank you. Thank you, John, Simon, and Dr. Gupta. I'm going to talk about management of the posterior fossa medulloblastoma. As you all know, the medulloblastoma is probably one of the most common CNS tumors in the pediatric age group.
Okay.
Yeah, moving to next slide.
Okay, click on the slide with the cursor, please.
Yes, I did.
Oh, you did? Okay. We went over this before, right? Okay, maybe are you clicking manually on the slide? On the left column, you're clicking on the slide?
Yeah. Yes.
Okay. How did we do this before, Suresh? We got it before, okay. Do you remember?
Yes, we did actually, you know. And just now also when I checked, it was working all right.
Yeah. How did we do it before?
Try a different view.
Try a different view?
Shall I?
What do you mean? What do you mean? Make it smaller?
Just try a different view, you know, whether it's in presentation or just slide mode. And
try the slide mode.
And I'll just edit this out, so no problem.
Yeah, we'll edit this out. Don't worry. Okay, you're on the slideshow. Try something different. Okay, Suresh?
Okay.
Yeah,
I'll try something different.
Try something different, because obviously this is not working. Maybe put it on home. At the top, put it on home, and then just click on the slide with your cursor.
Just get.
The slideshow is still on. At the top, it looks like it's still on.
Can you see now?
Yeah, there you go. Whatever you did is the right thing. Okay, very good. Okay, we'll edit all that out. Don't worry. Okay, you want to start at the beginning?
Shall I continue?
Yeah, you start at the beginning.
Okay.
Okay, very good. Okay, we can start now.
All right, let's start again.
Okay, good.
Management of medulloblastoma. As far as the tumor is concerned, I think this is the most aggressive neuroepithelial tumors of cerebellum. The incidence is about 1 in about 200,000 children under the age of 19 years. About 6% to 8% of all CNS tumors are medulloblastoma, and pediatric CNS tumors, the incidence is about 15 to 25% of medulloblastoma. As far as the adult are concerned, this tumor is also found in adult, but much less incidence, which is about 0.4% to 1%. This is by far the most common posterior fossa tumor in children, which is found in about 38% of all the pediatric age group. This is also the most common malignant CNS tumor in children. In the past, this tumor has been associated with very poor outcome. The mortality rates were as high as 32% to 100%. However, in the recent years, with the advent of modern MR imaging, early diagnosis, and improvement in the neurosurgical equipment and technique, as well as the improved delivery system of radiotherapy and chemotherapy protocols, it has now been possible to reduce the mortality rate, and the survival in the recent publications is about 60 to 70% in 5 years. As you can see on this slide, in Indian most busy neurosurgical centers in India, the medulloblastoma rank number 2 in the incidence, just after astrocytoma. If you consider north part of the country, south part of the country, and east and west, it is the second most part common tumor in India as well. Okay, There is always a male preponderance. The mean age or the age of diagnosis is about 13 years overall. However, in the pediatric age group, it is found in about 3 to 12 years age group, and in the adults group, it is common in about 21 to 40 years of age. The location is very typical. It is always found, or most of the time found, in cerebellum in about 94.4% of the times, to 88% of the children. Cerebellar hemisphere is much less preferred site for this tumor, seen in about 8 to 10%, and that too in the older children and in adults. There are various uncommon locations also where you do find medulloblastoma at times, and which include floors of the fourth ventricle, supratentorial part of the brain, as well as the spinal cord. The brainstem infiltration is usually found in about 33% of the cases at the time of diagnosis. So you can see how common is this tumor. The symptoms usually includes those of raised intracranial pressure as well as the posterior fossa involvement. So children do present with headaches, persistent vomiting, visual impairment, diplopia, imbalance, nuchal pain, and lower cranial nerve involvement. On examination, you would see papillary edema, truncal ataxia, the cerebellar signs, diminished vision, cranial nerve palsies including sixth, nystagmus, seventh cranial nerve palsy, as well as the lower cranial palsy. What is typical about this tumor is the appendicular ataxia and the spasticity, as well as dysmetria, which is seen in about 17% of these patients. Now, the recent investigations facility has improved so much that you can diagnose and characterize these tumors very clearly. The CT scan was initially the choice of investigation, and on the CT scan, you do see a round, regular, hyperdense mass in most of the cases, which is the roof of the fourth ventricle in the verbase, actually obstructing the CSF outflow intraventricular and causing obstructive hydrocephalus. This is a typical picture on a CT scan. When you do give contrast, there is a fairly good contrast enhancement after on the CT scan. If you have any metastatic lesions, you do get to see those also after the contrast enhancement. However, MRI scan is the choice of investigation in these patients, because it not only diagnoses the tumor, also it can give us some differential diagnosis, and it throws light on the involvement of the CNS, whether it is limited to posterior fossa, whether it is extending into the supratentorial or brainstem or in the spinal cord. On MRI scan, typically the tumor is seen as an isointense or hypointense on T1, which turns to hyperintense on T2. There is moderate or to higher contrast enhancement, and there is heterogeneous morphology of this tumor. What is common is the extension of these tumors. They do extend through the foramen of fourth ventricle and extend into the CP angle, cisterna magna, and other CSF cisterns. MRI spectroscopy is not that typical of medulloblastoma. However, it does show increased choline peak, decreased Na, decreased creatinine, and increased lipid lactate ratio. Okay, these are various different extensions of the tumor. Here is tumor in the fourth ventricle occupying almost complete be located in the lateral part of the hemisphere, where the desmoplastic variety is more common. This type of tumor is absolutely not enhancing, and there is a cyst, and the cystic wall is enhancing. In this tumor, the enhancement is like hemangioblastoma, a typical nodular hemangioblastoma with a large cystic part located in the peripheral cerebellar tissue. Then you do get to see various emanations. So this is the tumor with hemorrhage within it. These two slides showing hemorrhage within the tumor. Here is the large tumor occupying in the midline fourth ventricular region, and the tumor is herniating into the cervical foramen magnum. Here the tumor is herniating into the CP angle through the foramen luschka. This is the tumor where the tumor is extending superiorly, herniating superiorly through the hiatus of diaphragm of tentorium. Here the tumor is completely located and enhancing and attached to the undersurface of the tentorium. So you do get various types of MRI picture imaging on imaging modalities at times, but the typical characteristic picture remains the same. This is a very important slide showing multiple spinal drop metastasis as well as the spinal leptomeningeal spread, which is seen in about 33% of the patients. Brain stem infiltration is also seen in equally 1/3 of the patient. And more importantly, extraneural metastases, which are seen in about 7.1% of the patient, and they involve bones, lymph nodes, liver, lungs, and muscles. So you can imagine, how extensively spread you do get to see sometimes when the tumor is of very high risk variety. Differential diagnosis is very simple, typically involves ependymoma, pilocytic astrocytoma. These are the main three things which come into the differential diagnosis of this tumor on imaging. However, you do see hemangioblastoma appearance with medulloblastoma, sometimes lymphomas in adults, metastases. These are the very common pictures. Sometimes, very occasionally, you get Lambert-Douglas disease, which is dysplastic cerebellar gangliocytoma, looking exactly like a medulloblastoma. However, there is no enhancement whatsoever in this disease as opposed to the medulloblastoma. As far as the management is concerned, we have surgery, radiotherapy, and chemotherapy to offer to these patients. There has been a great advance in the management of medulloblastoma in children in the recent years. The surgery is very essential, and the aim is to establish diagnosis, do a cytoreduction so that the tumor burden is minimized, and then at the same time you do the establishment of the CSF flow intracranially. We have seen outcome in complete resected tumor versus resection versus biopsy. You do get to see that there is a vast difference in the survival in these patients who had undergone complete removal. Also, it has been found that when the residual tumor is left about less than 1.5 square centimeter, the prognosis is much better as compared to those in whom the residual tumor is more than 1.5 centimeters square in volume. So it does increase. There is no confusion, no doubt about it. Operative mortality in the early part of the last century, the operative mortality used to be more than 50%. However, with the advanced treatment modalities in the 90s, the operative mortality was reduced to less than 10%, and currently the mortality rate is about less than 2%. Radiotherapy forms very important part of the management because these tumors are radiosensitive tumors, and usually what is the protocol is to give a combination of surgery with radiotherapy, and this is the most successful regime so far we have seen. And when it comes to radiotherapy, it is the craniospinal axis which has to be radiated. This is very important. Recently, now there have been a lot of work going on about the attenuation of radiotherapy doses, and with that the progression-free survival has been increased to about 60 to 70% of the patients. Also, chemotherapy, which is the most recent part of the treatment. It has been the first trial was conducted in 1980s. It increases the survival rates in high-risk children. Unfortunately, the role of chemotherapy in the average risk patients has not been defined very clearly, but we'll go back to it afterwards. It also reduces the dose of radiation and thereby reduces the toxicity of radiation and neurocognitive functions in 3 years of age and are less young children. Treatment modalities, surgery, radiotherapy, and chemotherapy, it has now been possible to increase the cure rate to about 70% to 80% in most of the cases. When it comes to surgery, you have to identify and choose the correct approach. So when the tumor is located in the midline, you do the Vermean splitting approach. When the tumor is located lateral into the cerebellar hemisphere, then I think transcorticular cerebellar approach, the correct approach. When the tumor is extending into cerebellopontine angle, then telovelar approach is usually chosen. When the tumor is superior to the superior part of the vermis, you choose supracerebellar approach. And when this disease is very extensive with the leptomeningeal spread, the diagnosis is never in doubt, and most of the times all you need is to take a biopsy, which you can take safely from the biggest lesion. So surgery is a very, very particular position involved in this patient, and most of these surgeons prefer sitting position, and prone position in the is chosen by the other surgeons. However, there is always a debate whether to choose sitting position and prone position, and at least in my mind it is very clear that it comes by the type of operative setup you have at your center and the surgeon's preference. So when you do surgery, we do usually in prone position, and you do the midline skin incision, and you make a bone flap which is extending from the level of transverse sinus and the torcula superiorly down to the foramen magnum. You open the dura, which is arachnoid is identified. The arachnoid is then open, arachnoid of the cisterna magna, and the CSF released. This release of CSF helps in relaxation in the entire posterior fossa. Later on, you have to do all the arachnoid adhesions reduction here so as to re-establish the CSF pathways, so that patient doesn't require any CSF diversion procedures later on in their life. So this is after opening the dura. You go into right midline and split the inferior vermis, and then you see the tumor. At times, when the tumor is not appearing on the surface, you do take the help of various intraoperative navigation system, and I take usually the ultrasounds help, and it is very good. You know, you can see the tumor very well, the extent as well as the consistency. It gives a very good idea where to make the opening. And then after splitting the vermis, you do see the tumor, which is usually removed by usual instruments. So you can also use QSAF or any kind of aspirator to debulk the tumor. Once you have done the debulk the tumor, you then move your dissection to the superior part, and you identify the aqueduct and the upper part of the fourth ventricle, and there you can see the clear CSF fluid coming. So your superior part or superior border of the tumor has been taken care of, and then you move on downwards and go right up to the inferior part of the pons, where you can visualize the entire floor of the fourth ventricle can be visualized. Once you have identified and opened up the aqueduct, you have to plug it temporarily in order to prevent air to migrate into the intraventricular system. So once the fourth ventricle has been identified completely and cleaned up by the tumor, then you move on the lateral side and you keep removing the tumor until you find the normal cerebellar tissue. And then, of course, you have the ultrasound to help you out. You see if there is any residual tumor left, and if it is accessible, you can go ahead and remove that as well. A good watertight dural closure is equally important. Replacement of the bone flap is also essential, and then the usual way of wound closure in layers should be done. So this is one example. A large midline Vermean tumor, medulloblastoma, which is seen after the dural opening, and then this is after the removal of the tumor. You can see the nice shining floor of the fourth ventricle after complete clearance of the tumor, and this is the post-op MR showing complete removal of the tumor. There are several debatable points in surgery. One is the patient position, whether to do a sitting position or a prone position, and then there is management of hydrocephalus, whether to do a pre-operative CSF reservoir or post-operative or do a ETV. Extent of tumor resection, again, it depends. If it is infiltrating, you become less aggressive. If it is well defined, then you can remove the tumor completely. The idea is to, or the goal is to remove, do a safe tumor removal as much as possible. You avoid brain retraction and avoid the incidence of cerebellar mutism, brain infiltration, brain stem infiltration, and pica. These are all debatable points, and you need to discuss with the family members and amongst your colleagues whether to it is advisable to take that risk, and again the pathology of the tumor, and what watertight dural closure is equally important, as I said earlier. So these are the positions. The most common side effect complication of the sitting position is the air embolism, which has been seen in very high incidence in the literature. Besides that, there are other seen with the acute stages associated with the prone supine sitting position. However, with the latest technology and availability of all these things and the awareness and observation, we can minimize this incidence to almost nil or less than 1%. Management of hydrocephalus, it has been observed that about 1/3 of the patient require preoperative CSF diversion procedure. About 1/3 of the patients require postoperative CSF. About 30% of the patients do not require any kind of CSF diversion. So what we do nowadays is you open up the basal arachnoid spaces and re-establish the CSF flow during surgery, so you can avoid the need of a CSF diversion procedure post-operatively, because the VP shunt has been associated with several untowards or associated risks of complications with exclusively associated with the shunt. So and to re-establish the CSF flow in these patients, and that is up to the surgeon's own judgment during the surgery that how much tumor is enough, tumor removal is enough. Cerebellar mutism is also very common, and it is particularly common with the vermeer lesion and medulloblastomas. So there are various causes, but what we need to do is try and avoid the excessive aggressive surgical manipulations. Cerebellar retractor should not be used with very much pressure or retraction, and sometimes it has been found that even CUSA can lead to cerebellar mutism, and some vascular insult is also. Radiotherapy, as we discussed earlier, radiotherapy forms the most important part of the management, and craniospinal radiotherapy should be given, and with this the success rate is about 45 to 60%. However, there are long-term sequelae, particularly in the younger age group, including neurocognitive deficits, growth failure, endocrinopathologies, and secondary malignancy. So you have to be aware of this thing. In the future, there are going to be various studies coming up very soon in the future about the proton beam therapy, and we'll have to just wait and see how proton beam therapy helps these children. Chemotherapy, as I said again, should be reserved for the high risk group, and it should be given in those patients who are not suitable for the radiotherapy, such as the children younger than 3 years of age. Dose attenuation therapy is nowadays very common, and it has a lot of studies are going on. The idea is to reduce the dose of craniospinal spinal axis so that you can reduce the incidence of or the risk of toxicity, and that can be done by dose attenuation and adding chemotherapy in the treatment of the patients of medulloblastoma with average risk group. In the high risk group, yes, of course, you have chemotherapy and radiotherapy as an adjuvant therapy to the surgery, and you have to do the standard dose and then the high dose spinal RT as well as the boost dose to the posterior fossa as well as the spinal metastasis. So the goal of current therapeutic approaches, it has been very well defined nowadays. It is actually to differentiate high risk from the average risk patients. Why? Because the treatment of high risk medulloblastoma patient is different than the average risk. You can choose different pathways according to what you get, whether it's a high risk medulloblastoma or it's an average risk. So medical aggressiveness rather than histopathological or clinical diagnosis and also to minimize the treatment related long-term side effects in the younger kids. So this is the risk stratification. In the old age, we had only clinical criteria, which is age, residual tumor, and metastasis. But we have recently found that the only clinical risk stratification criteria given by Chang's classification, Chang's staging system, are not enough to define the nature of the tumor and to decide about the further management. There are several shortcomings of the clinical stratification. WHO classification defines the medulloblastoma as grade 4 CNS tumor, but we so now is also been different. All of them cannot be clumped in one age group, and they differ according to their histopathological subtypes, extent of nodularity and grade, extent of anaplasia, desmoplasia, cell differentiation, proliferation labeling index, apoptotic index, and ploidy. So based on these factors, histopathological factors, we can now divide the medulloblastoma in 6 broad classes. One is the classic medulloblastoma, then the desmoplastic or nodular medulloblastoma, and then medulloblastoma with extensive nodularity, anaplastic medulloblastoma, large cell medulloblastoma, and melanotic medulloblastoma. We also have few more types of medulloblastoma which do not fit into any system. So we will not talk about these things. So histopathologically, at least based on their histopathological, now we have come to identify those tumors which have favorable outcome and those tumors which have unfavorable outcome. So all those patients who have desmoplastic histopathological features or nodular, extensive nodularity, and which is about 96 to 100%, no anaplasia, and GFAP positive, which is neuronal differentiation, and apoptotic index, which is more than 1.5, have a favorable outcome as compared to those who do not have. All these patients, tumors have unfavorable outcome. So now there is a molecular stratification criteria and factors which really are very helpful in determining the nature of the tumor, its biological behavior, not random chromosomal abnormalities like this, gene profile acting like this, or the abnormalities in signal transduction system. So there are several, at least the 4 important signal pathways have been identified, like wingless or Wnt, sonic hedgehog, and then ERB receptor, and the neurotropin system. So these signaling systems decide what kind of tumor or define what kind of tumor it is. So based on these criteria, now we have 4 types of medulloblastoma. One is Wnt, another one is hedgehog, sonic hedgehog, and then group 3 and group 4. So what is the difference? The age group in this, these are all older children or adults, while SHS will have smaller children as well as the adults. And group 3 have smaller children and slightly older children also. In group 4, all of them are included. Male female domination is also very well defined in the type of the molecular architecture. Clinical features, Wnt type of subgroup is usually associated with classic type, such as desmoplastic, this is classic, or large cell type of medulloblastoma, this is classic, and anaplastic type of tumor. These are the genetic chromosomal abnormalities, and gene expression is Wnt here, and SHS is here, and then so on. So based on this molecular classification, we can now define that which medulloblastoma is what type and how is the total prognosis depend on that. So the Wnt subtype has the best prognosis and has the lowest risk. SHH subtype has good prognosis and has intermediate risk. Group 3 has the worst prognosis and they are the highest risk of medulloblastomas. Similarly, Group 4 is also high risk medulloblastomas. They have the intermediate prognosis. So now, based on all these facts and points, we can now have the multimodality risk stratification in medulloblastoma based on the clinical imaging and histopathological finding and the molecular facts, and then you can divide those tumors into average risk as well as the high risk, and you can decide what kind of tumor, what kind of treatment should be subjected to each of these tumors. In fact, now there is more work being done towards redefining these groups, and they have defined the lowest risk, which is the Wnt, and then the standard risk, then the high risk, and then the very high risk, which includes these tumors. So IPP3 mutation group and the metastatic group, this very high risk, but do not fall into any of these categories. What is important is, this is probably my last slide, what is important is that now we can identify some of these medulloblastoma based on their biological behavior on the neuroimaging, MRI particularly. So there are certain MRI features which are very well defined as far as like location, whether it is horizontal, midline, laterally placed, and based on that you can decide whether it's a Wnt medulloblastoma, SHH medulloblastoma, or Group 3 or Group 2. So you can pre-plan your treatment strategy based on the MRI finding. If it is vertical, then it is central, it is superior, inferior, or inferior. Again, the brainstem involvement, whether the brainstem is infiltrated, uninvolved, or displaced. Contrast enhancement, whether it is homogeneous or moderate, whole type of enhancement. Similarly, T2 weighted iso-intense homogeneous enhancement, variable and heterogeneous enhancement, iso to hyper and homogeneous enhancement, and hyper-intense and homogeneous enhancement. Tumor margin can also be defined on the good quality neuroimaging, which is the lobulated or whether it is smooth or infiltrating, peritumoral edema, calcification, hemorrhage, intratumoral cysts, association of hydrocephalus, and metastasis. All these factors can be picked up very well on the MRI scan, and that can define whether the tumor belongs to this group or this group, this group or this group, or whether what is the treatment policy and what is going to be the ultimate prognosis of these patients. So this is an example. MRI scan, laterally placed, beginning from the midline and going laterally. This is a typical of Wnt subgroup of medulloblastoma. As opposed to this one, this is completely laterally placed desmoplastic variety, SHS subgroup. This is Group 3, which is juxtaventricular subtype. It is less infiltrating, we can see, so it is less aggressive, but it is Group 3 medulloblastoma. You can see the fourth ventricular ependyma surface is very well protected, as opposed to this, so this aggressive type has the brainstem involved. This is a less aggressive type, brainstem is not involved. This is a Group 4 subtype, which has got a cotton wool type of tumor, big mass in the fourth ventricle. Some part of the tumor is herniating into the foramen magnum as cisterna magna, inferior location. There is always already there is leptomeningeal enhancement suggesting of metastasis, and there is hydrocephalus. So this is going to be a very high risk medulloblastoma. So our conclusions are: medulloblastoma is the prototype of treatment success in modern pediatric neuro-oncology. Safe maximal surgery combined with appropriate radiotherapy and CT is the present standard of care. Clinical criteria alone are not adequate for planning therapy. Histopathological features and newer molecular techniques are important to identify subgroups needing more aggressive treatment for better control and control de-escalation to minimize toxicity. And multimodality risk stratification is very important to rationalize approaches to therapy, to increase cure rates and reduce long-term side effects, and to provide strategies. With this, I conclude my talk. Thank you very much.
Okay, thank you very much, Dr. Suresh. Excellent presentation. And those,
have I exceeded my time?
I'm sorry?
Have I exceeded my time?
Yeah, you can get off the screen share by clicking on the green arrow there.
Yeah, it's taking its own time actually.
You can click on that green arrow.
Can you hear me now?
Yeah, we can hear you.
Any question?
Yeah, just click on the green arrow on your menu on the left side of your screen.
Any comment?
The left side of your screen. There should be a menu with a green arrow.
Yeah.
That'll you're getting there. There you go. There you go.
Yes.
Yeah, that was a great presentation. Very clear slide. Very, very clear. I'm sure you've given that a comment.
Is Dr. Deepak with us? Is Dr. Deepak with us?
Yeah.
Dr. Deepak Gupta?
No, he stepped out, I think, for a second.
Oh, but, fine, no problem. Okay, go ahead.
Okay, Simon, do you have any comments or questions for Suresh?
Yes, please. Thank you, Professor, for your presentation. I have a medical student question. This is regarding...
your audio is bad, Simon. Yeah, just click on your audio there. It's kind of garbly.
Is it?
Yeah, Simon has a good...
Can you hear me now? Can you hear me?
Yeah, it's still kind of garbly, Simon. Still kind of garbly. Sorry about that. We're getting better at this technology.
How's this now? How do you hear me?
Excellent.
Okay, I have a question.
Yeah, I can hear you better. Yes.
Thank you. A kind of a medical student kind of question regarding medulloblastoma. And I understand that you now have a 70 to 85% cure rate. I was wondering whether some of the techniques you have been able to apply to achieve this excellent cure rate can be applied to things such as pontine gliomas. I know there's a totally different type of tumor, but are we getting closer to, coming to this level?
Yes. Correct. You're right, Simon. I think we are working towards the brainstem gliomas as well. But medulloblastoma we have been able to identify the subtypes, and not all medulloblastomas are good. Not all of them have 85% cure rate, but we can pick up those medulloblastomas which have good features and then treat them very aggressively. Then we can achieve good cure rate. In brainstem gliomas, things have not been as clear as they are in the medulloblastoma. So it might take a while before we really identify those molecular features, which are, we can classify the brainstem glioma also in the favorable group and unfavorable group. Until that time, the prognosis of brainstem gliomas remains rather gloomy.
I see. Thank you very much.
Doctor, if some child with this type of tumor, would a general neurosurgeon operate on him, or would he be sent to a city with a pediatric neurosurgeon?
I think now, as we are knowing more and more about this tumor, we are becoming, very, very sub-specialized type of surgeons. Not all pediatric neurosurgeons also. So pediatric group or surgeons or team is the one which should be dealing with these kind of tumors, because it is not only the surgical part, it is the radiation, then chemotherapy, and overall management, which really makes all the difference, not one. So even if you do a good surgery and you don't do the good radiation and chemotherapy follow-up, your results will not be as good as they should be. So I would really suggest that there's any center which has a good pediatric neuro-oncology center. Those are the centers where medulloblastoma should be treated. I know it is very difficult, but we are moving in this direction to develop various centers in India at least, so that we can give a good quality care to these patients.
Mm-hmm. Okay, very good. Okay, doctor, I'd like to thank you for taking the time, and this is all recorded. We'll give you the link for it, and thank you very much for coming out.
Thank you, John. Thank you very much, and Simon, thank you.
Okay, very good. Okay, Doc, it's over. We're gonna edit. We're gonna edit this out and stuff. Yeah, that presentation. Oh, we've gone. Okay. Mm-hmm. Okay. Well, dog. I don't want to. I don't want. In other words, the mic doesn't work at all, huh? In other words, it doesn't work at all.
Yep. Doesn't work.
Well, you know what? I had my windows. I had to change again, and when I changed the window, all of a sudden, the audio is coming in through my mic, but my mic's not working.
Okay.
I don't want to reboot. I just can't take a chance.
Don't. It sounds fine.
Yeah, and I'll have to, unfortunately, I don't like this either. I like the speakers, but I can try one adjustment. Let me try on the just like how you have to go into the control panel and reboot and stuff.
Yeah,
I can't mess with it. I can't take a chance because it might say I went through like 2 hours trying to get back on, and that'll be a disaster. So we'll just leave it as it is.
And I have a question. Are you able to use your control panel to unmute the person I muted?
The control panel to unmute who? The gentleman that came in?
Yeah, that I muted, yeah.
Yeah, go to...
No, I don't have it. You have the control panel.
Oh, okay. Yeah, the control room. Yeah, you go to the control room.
Yeah, you can probably unmute him. If not,
okay. Let me try it here.
He can be booted and then come back. He'll be.
Is he unmuted now?
No. Okay, you did it. Okay, it works.
Oh yeah. Okay, he is unmuted.
So then we should be able to mute when because we.
Hello, Nathan. Natarahan, are you there? Okay, let me make sure the. Well, dog, we can end right now if you want, and start another one.
Up to you. You could even reboot. I don't know. It's up to you.
What's that?
Your mic sounds fine to me, though, so maybe no need to reboot. But
you want to end the video now and start another one?
If it's not too much trouble, yeah.
Yeah. Okay. The tower. Okay.
Up to you.
I'd like to tell him that.
Yeah, it's okay.
Yeah, we'll just do another one, I guess. And then we start a long one, a 2-hour one.
Okay, then you might need to.
Yeah, let me get the next speaker. Big neurosurgeon.
So my mic doesn't sound good now, huh?
Now it does.
Now it does, okay.
Yeah, now it does.
Good.
Yeah, these aren't bad once you get rolling.
Yeah, they're good, very good presentations.
Man, that was a quality one. There's pictures and the way he was moving his mouse around.
Yeah.
I tell you, a student's going to love that. I'm not getting too much out of it, but if I was a student, neurosurgery, wow.
Yeah, I learned a lot.
Yeah. Yeah, I mean, these are quality presentations, and I was going to ask him. You do that? You give that at conferences probably. Same talk.
Do you have live viewers at the moment below you? Can you see?
3.
Okay.
But I don't know if that's accurate. I'm trying to get the IT guy from the hospital. He said it was being televised in the hospital at one point.
Yeah.
Yeah.
Also, you.
Yeah, you're right. You're right about that. You're right. Exactly right. I can tell by stats. I can tell by the stats.
Your pings are loud and clear, by the way. I guess you want to keep them on, huh?
Well, you know, I don't want to keep them on. I try turning them off. Where do you turn them off?
All right. Just leave them then.
No, where do you turn them off?
At the top, there's a settings button.
Yeah, but I see options, right? No, that's you. That's you. Okay.
That's all right. Don't mess with it.
Where does it have? Notification. Oh, notifications. Oh, I see.
That's it. That's it.
You got to turn it off. Okay.
Yeah, I'll do a trial now.
Well, you know, I like to hear notifications. I want to put it back on because people want to get in or the speaker or something.
All right. All right.
Yeah, and I don't get that many really.
Okay.
So let me see, Dr. Jane, big neurosurgeon, man, big. Head of societies.
Here we have Dr. Jane is here.
Oh, okay.
Yes.
Hello, Dr. Jane, how are you?
How are you, John?
Very good. Good to see you.
Yeah, I'll click on this green one.
Yeah, not yet, but yeah, let's just rehearse.
Yeah, you can try it.
Rehearse. Yeah, first you actually exit the Hangout by minimizing it, and then you open the PowerPoint on your desktop, and you come back to the Hangout.
Okay.
Okay.
Hold on.
Let's rehearse. We got a few minutes.
Yeah. This is the PowerPoint.
Okay. Now go into the menu on the left side and click on the green arrow.
So I will minimize this one.
Yeah. No, leave the PowerPoint there. Don't minimize it. Leave it there, and then come back into the Hangout.
Yeah.
On the tab, and then go to the green arrow on the left menu, and then pick the PowerPoint. It should be an option there. It says, which screen do you want to share? You want to share the PowerPoint.
Yes. Right.
Yeah. Okay. Perfect. Perfect. You got it. You got it. You remember.
Hear me clearly?
Yeah. You hear you clearly and see you clearly. That's excellent. Do you have a son that's a neurosurgeon?
Do you have a son that's a neurosurgeon?
No, I don't have a son who is a neurosurgeon.
Oh, okay.
Right?
Because there was a neurosurgeon, Dr. Jane from India, a younger fellow that friended me this morning. I thought, wow, it's Dr. Jane's son. No.
Yeah, quite a few Janes are there.
Oh, okay. The common name in India?
Yeah.
Okay.
So you will tell me when to start, okay?
Yeah, okay. We have about 9 minutes. So,
yeah.
So this was being televised in the hospital.
Okay.
It was. Matter of fact, this part will even be televised while we're talking now. So be careful what you say. So are you? Do you are you a pediatric neurosurgeon, doc, or a general neurosurgeon?
Yeah, I am a general neurosurgeon, but I have a lot of experience in pediatric also.
Yeah, and pediatric.
Yeah.
Oh, okay. So you do some teaching, right?
Yes, yes.
Okay. At a university, or where do you teach?
Yeah, I was in university back. Now I'm in corporate hospital.
Dr. VK Jain is here?
Yeah.
Okay. Sir, good afternoon. Deepak here. How are you, sir?
Good afternoon, Deepak. I'm fine and I'm ready for my job.
Great, sir. We look forward to your talk, sir.
You can see me?
I just logged in, sir. I was actually came to main names for my patients rounds and I just saw you now.
Okay. How many people have joined?
Right now there's a couple of Nataran and Dr. Dwarakana. I'm sorry, I can't pronounce the last name.
Dr. Dwarkana,
Yeah.
Dr. Sandra.
Dr. Srinivas is here, but apparently he's stepped away.
They are all speakers, you know. I'm just asking if some other people also have joined.
Yeah, yeah. they're yeah, a couple of neurosurgeons, 3 actually. 2 are stepped away, I think, from the desk.
Okay. So there is a live streaming of this program in AIMS.
Okay, now to get off the screen share, Dr. Jane, you click on the green arrow again to get off it. So I can introduce you, and then you could introduce us, you know, talk about what you do and stuff.
So
and in a few minutes I'll introduce you, and then we'll start.
So I bring my presentation PowerPoint?
Yeah, not yet. After I introduce you, and then you go into the PowerPoint. And we haven't started yet. Right now we're not taping. We're not really live taping because this will be edited out.
Yeah.
The beginning will be edited out, and we'll start when I say now live from New Delhi, from Miami. You're in New Delhi, right?
Yes.
Oh, good. We get a chance to see Dr. Natarajan. Natarajan, hello. Can you hear me?
Dr. Muthu Kumar.
Yeah.
Muthu Kumar.
Natarajan, when you're not
I'm able to hear you.
When you're not speaking, you have to mute your microphone. That's at the top of the screen. There's a picture of a wheel. It says settings. You gotta click on. No, okay, I'm sorry. At the top of the screen, there's a microphone with a cross on it. You click on that to mute. You see, like Simon. See, like Simon is muted.
9 once.
Yeah, you have to click on that thing when you're not speaking, but otherwise we get background noise. There you go. There you go. Okay, excellent, excellent. And when you speak, of course, you got to unmute.
So, Manu, Jerry?
Not yet. Not sure. Deepak, you're in the, hang on, 2 spots.
Click on it. It'll become red.
Probably 2 computers.
He wants me?
Probably in a smartphone and the.
So now you want me to join?
Not yet. Just I'll tell you when. You want to start on time. Oh, another someone else, Malvika. Okay. Now, Malvika. Oh, hi, I'm Dr. Bennett. Okay, that's it. Very good. You're muted. Is your camera working, Malvika? Because I just see an icon. I don't see your camera.
Hi. It's working, but it's going to be off.
Okay, now Malvika, we're getting a lot of feedback. That usually means that your speakers are close to your microphone, or you have 2 computer devices on. Okay. Oh, you're with Dr. Okay, Dr. Jane. Okay, we're getting feedback. Okay, when you're muted, we're not getting feedback, but when you're unmuted, we're getting feedback. Okay. Okay, I guess we'll start. You ready to go? Okay, you won't be turned video. That's fine, Malvika. That's fine. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett, televising for Neurosurgical TV from Miami. We have here another conference in the overall conference of Pediatric Neurosurgery in collaboration with Deepak Gupta of the Department of Neurosurgery of the AIIMS Hospital in New Delhi. Today we have the pleasure of having Professor Jain. He's going to be talking about management of CBJ anomalies in children, personal experience. But first I'd like to introduce the panel before I turn it over to Dr. Jain. Hello, Deepak.
Hello. Dr. Jain, welcome on this platform, and I want to thank you for sparing out your time to share with us your valuable experience on craniovertebral junction anomalies. And I know that you have the largest amount of experience in India, and I'm sure we look forward to listen from you, sir. Welcome, sir.
Very good. Natarajan, can you hear me okay? Can you introduce yourself, please? Unmute and introduce yourself. You can?
Thank you, Dr. Deepak.
Well, we left there for a moment. Okay, Simon, welcome.
Hello, Professor Jane. My name is Simon Downs. I'm in Tokyo, and it's a pleasure to be here as a medical student to enjoy your presentation. I'm looking forward to it. Thank you very much.
Very good. Welcome, Dr. Jane. It's all yours.
Okay, thank you, John. Thank you, Mr. Simon, and thank you, Dr. Deepak Gupta. So here I go. I start off.
Yes, please.
And let me tell you, this is my first experience to be presenting online.
Okay.
So there might be some hits here and there. Please excuse me for that.
That's okay.
And this subject of CV junction anomalies is quite a vast subject, and it is not easy to cover it up in such a short time. So what I'll do, I'll just talk about some of my ideas which are there, and hopefully I will be able to explain those things. So I will concentrate only on few small points. So mainly when we talk of CV junction anomalies.
You want a screen share, Dr. Jane?
Yeah.
It's not screen sharing yet.
I have to share the screen, yeah.
Correct.
No, I think now we can share the screen.
Yes, we can see it. Perfect.
Yeah. So when we talk about CV junction anomalies, there are mainly three management issues. One is atlantoaxial dislocation. The second thing, many people what they call as basilar invagination. And third thing is Arnold-Chiari malformation.
What, you fell off the screen share. Go back on, please.
Just full screen, I'll do that.
Not yet. Not yet. There you go. There you go.
Yeah. Now it's full screen, I think.
Yes, it is.
So as I was telling you, main problems are atlantoaxial dislocation, something called as basilar invagination, and Arnold-Chiari malformation. So I'll not be talking about Arnold-Chiari malformation today. I'll be basically telling about my thoughts of atlantoaxial dislocation and basilar invagination. So if we talk of atlantoaxial dislocation, the easiest one is reducible atlantoaxial dislocation. And what it is, I divide them in two types. One is mobile, wherein in flexion you have dislocation as you see in this picture, and in extension the dislocation reduces completely and the odontoid touches the arch of atlas anteriorly. The other entity called as hypermobile AAD, this is more dangerous, wherein in flexion there is a dislocation posteriorly, and in extension there is dislocation anteriorly of the C2. This is because the os odontoideum or fractured odontoid is lying above against the arch, between arch and the transverse ligament, but the body is free to move forward and backward. So in flexion, the body of C2 moves backwards, and in extension, it moves forward. It even goes under the arch of atlas. So the main thing to realize this is during anesthesia, we cannot intubate in extension position easily. We have to do, in these cases, we have to do fiber optic intubation, and we be very careful that we don't extend or flex the neck too much. Can you hear me? Hello?
Yes, sir, we hear you.
Yes, we can hear you.
Okay, so that was about reducible AAD. Now I talk about the fixed atlantoaxial dislocation, or which is called irreducible AAD. What does it mean? In flexion and extension, the dislocation does not reduce. You see in this picture, the jaw is near the spine here, and in extension it is so far away, but it is still dislocated. Another picture is here. You see the jaw, the mandible is seen near the spine, and it is so far away. So it is real extension at the atlantoaxial joint, but still it is not reducing. So this is called fixed. Some people say that it should be put on traction, and then we will call it fixed. Now there is another entity where people say fixed atlantoaxial dislocation with basilar invagination. What do they mean by that? You see, the odontoid goes inside the foramen magnum, and they call it as basilar invagination. Another picture, you see the odontoid is going inside the foramen magnum, so people call it basilar invagination. You see another picture, this is C2-3 fusion. C2 is completely inside, C3 vertebral body is against the arch of atlas. So this is called as basilar invagination. Now I'll further talk about this later on when I clarify these things. Yeah, another picture of basilar invagination. You see this C2 body is completely inside the foramen magnum, in flexion and extension both. Now now we have talked about two entities. One is fixed atlantoaxial dislocation, one is basilar invagination. Now when we talk about fixed atlantoaxial dislocation, I must tell you that the atlantoaxial joint is the most mobile joint of the body. And why should it get fixed? One has to find out the reason of fixity of atlantoaxial dislocation. Is it only X-ray which is not done properly? Is it muscle spasm in the neck which is not allowing movement at that joint? So, and once we talk of management of all these things, all dislocations should be reduced. If they cannot reduce on flexion, extension, traction, then we should open the joints, and by open method we should reduce all these joints. That is a basic fundamental management in all orthopedics dislocations. And if you cannot reduce it, then you have to do orthodesis in the position of maximum utility of that joint. Now, as I was talking to you earlier, that in a fixed atlantoaxial dislocation, we should try and find out what is fixing it and why it is getting fixed. And then we should treat that cause and not the effect. The effect is dislocation, where many times transoral surgery is done to decompress it. But if we can reduce it, we should first try to reduce. All efforts should be made to reduce that dislocation. So there are certain causes where I'll show you in traumatic, like if odontoid has slipped in front of arch of atlas, like this. In this picture, you see this odontoid had slipped in front of the arch of atlas. This just cannot be pushed back because the arch of atlas will prevent it. So by going transoral, we resect this odontoid and do reduction like this. You see, this is post-operative in reduced position. Another thing, in traumatic cases, there may be callus formation and fibrotic joints here. So, or pseudoarthrosis, which this will not allow it to come forward. Like this, again, these are so much engaged fracture segments. They will not just move. There's pseudoarthrosis here, and in third picture you can see the malunion in dislocated position. So you have to correct these things by going transoral and remove this and make it free. Then only it will reduce. So, and coming to basilar invagination, my idea of basilar invagination, you see these three pictures, 1, 2, and 3, and if you see all three are different. Are all these basilar invagination one entity? No, they are all different. So what we should do, you see, for basilar invagination, a lot of lines have been described, like this, and Wackenheim's line and all. These all lines were described at a time when we had only plain X-ray, no CT scan was available. So these lines were described at that time, and they could not see C1, C2 so clearly as we see nowadays. So nowadays these lines are not so important. What I say that these lines, and there are so many angles, they will give you indirect information between the cranium and axis, because one point is cranium, like palate, and the other point is again cranium, maybe posterior margin of foramen magnum or other margin, and so you just see how much above is the odontoid. So this is the relationship between cranium and axis. But we do not see if there is a problem at atlantoaxial joint. We don't try to look at the abnormal relationship of atlas and axis. So all these lines are like that. So what I call something like central dislocation. For me, so-called basilar invagination is central dislocation, where the C2 moves up into the foramen magnum. So in this picture, if you see, this is the foramen magnum, base of skull, what I call. If this base of skull goes up, then I would call it basilar invagination. And in that situation, the joints, atlantoaxial joint, you see in cornal here and you see in sagittal here, would be normal. These joints would be normal, and C2, C1, C2 and C1 relationship would be absolutely normal. So that you can call as basilar invagination. Like in this picture, you see this is the foramen magnum, but if you see C1, C2 relationship, joint, they are all normal. So this you can call as, and if you see base from posterior to anterior, it's almost flattened. You call it platybasia, you call it hypoplasia of clivus, basilar invagination, that's all fine. But this is not atlantoaxial dislocation. There is no atlantoaxial dislocation here. Another picture, you see such a high odontoid. If you will draw those lines, it will be called basilar invagination. But C1 C2 relationship is absolutely normal. So this you can call as basilar invagination. Yeah. So now normally this is very common picture in India when we see that there is a dislocation, the odontoid is going up. So this we generally call as fixed atlantoaxial dislocation with basilar invagination. But this is not so. You see this, you will call it basilar invagination. So what I call it is depicted in this picture. When the C2 goes up, I call it axial invagination or central dislocation. Then there will be, this joint will not be normal also. You will see some abnormality, dislocation at the joint also. So this we will call as axial invagination or central dislocation. Just an example, you see here in this MRI, so much of axis has gone up, so it is axial invagination. In this CT scan, you see this axis C2 has gone completely inside. So I will call it as axial invagination. So again, coming back to the management, all dislocations should be reduced. If they cannot be reduced by closed method, then they should be reduced by open method. And then orthodesis should be done in the position of maximum utility. Now, how do we plan surgery? We have to see all these CT scans in 3D and sagittal, corneal, and make 3D imagination and find out what is the abnormal relationship between atlas and axis. What is the problem at atlantoaxial joints? And then determine the direction of abnormal displacements, whether it is gone posteriorly, has it rotated to right, it has rotated to left, or it has gone up. And then you have to reverse these displacements to restore normal anatomy. For doing this, you have to open the C1, C2 joints, align C1 and C2, and then fuse it in the reduced position and reduced condition. So we have three approaches for that, mainly two, posterior approach and transoral approach. But sometimes you can go posterior and not able to reduce it, then go transoral and remove the offending element and then go again posteriorly. So now I'll just show a few examples. The trick lies in understanding the orientation of the joints and changing it to get normal alignment of atlas and axis. So this 12-year-old boy who had orthodontoidium and fixed AAD, you see this is the MRI, you can see this atlantoaxial dislocation, and here is the right side joint, here is the left side joint, there is some dislocation, C2 is behind, C2 facet is behind the C1 on both sides. Now you see in the CT scan, again, this is the joint which is seen, C2 is little behind. So this should go down here, and this is again in flexion you see, and this is in extension. This is not reducible, but you can see the joints. They are seen beautifully. So what is required is this arch of atlas and C2 should come together here. So you should rotate it in such a way, that this moves forward, this moves forward, and this goes up. So you see this is the pre-op CT scan, this is the post-operative CT scan. We have done bilateral transarticular screw fixation, and this is completely reduced in mid-sagittal view. And here you see this joint, this surface has come down, which was here. So it has rotated like this, and it has reduced completely. And we have done bilateral transarticular fusion, and in the midline we have done sublaminar wiring and bone fusion also. Another 16-year-old boy who has got congenitally C1 assimilated C2-3 fusion, so-called fixed atlantoaxial dislocation, and so-called basilar invagination. See this plain X-ray, he had traction for 7 days, no change in plain X-ray. In this MRI, if you can see this, you see this joint on the right side here, joint starts, you can see from here, come up to here, and then midline there is this basilar invagination so-called, and then again you move to the left side, you see this joint again. So again the same thing, this has to be moved forward, and then it will reduce. This should come down. So you see in 3D view, joints are beautifully seen on both sides. So there is nothing which is preventing movement between the joint or between C1 and C2. So this is after surgery. This has moved completely down and reduced here, and then we have put transarticular screw here, and you see this joint. C2 has moved forward and downward. C2 here has moved forward and downward. So this is completely reduced. And now we move on to another 17-year-old girl who also had C1 assimilation, C2-3 fusion, fixed AAD, and so-called basilar invagination. Okay. I'll just take 1 second. Excuse me.
Okay. You're going to show a video, or because you're off the screen share, Doc.
Okay.
You're not off the screen share. Unmute yourself.
Yeah, you're off the screen share.
Yeah, now
Okay.
it's okay.
Yeah, you're back on, but it's not as big as it was before.
Right.
There you go. Perfect. Perfect.
This is another 17-year-old girl. Here you see this. I have just made these arrows to show that this should move forward and this should move downwards. If we can do that movement by opening these joints, you see, right side joint and left side joint, just push it forward and downwards, it would completely reduce. So-called basilar invagination and dislocation both would reduce. And you see this in this picture, these are the pre-operative ones and this post-operative one. The odontoid has completely come down and touching the arch of atlas here, and then this is transarticular screw on right side, this is transarticular screw on left side. See the difference between the joint here and joint here. The orientation has completely changed, and then this is posterior fusion by making arch of atlas and laminar screws, sublaminar screws. This artificial arch of atlas technique I have described long back, so I'll not anyway go in details of this technique now. And coming to next patient who had fixed AAD, basilar invagination, Arnold Cherry malformation and shrinks, all things in one boy. So here you go, you see this MRI, you can see this Arnold Cherry malformation, syrinx, and this is the dislocation here. These are the CT scans, dislocation with a little bit of basilar invagination, and this joint. These joints do not appear to be dislocated. Even then there is dislocation, so we have to move C2 forward and downward again, mainly forward. And if you see these post-operative images, this C2 has moved so much forward, and on this side also it has moved so much forward, and here it is completely reduced. And we have done foramen magnum decompression also, and this is what you are seeing as the rib graft on right side, and this is on the left side. And this has taken up, the patient has come for follow-up after 4 years, and this is completely taken up rib graft. Now there is another patient where I went first posteriorly. This is 12-year-old boy with osodontoidium and fixed AAD, and this patient was admitted in orthopedics. For 14 days he was on traction, but there was no change in the dislocation. It did not reduce. And you see the CT scan, it appears to be odontoid, os odontoidium. This child had history of fall during last 1 year 3 times. Every time he developed quadriplegia. Last fall was 3 months back, and from that quadriplegia he did not improve, and he was bedridden. He had severe spastic quadriplegia. So, but I thought these are the joints. If you can see this joint on this side, this joint on this side, I thought probably it will move forward by going posteriorly, opening the joints. There is some osteophyte formation also here. So when I went posteriorly, I opened the joint. So joint was free. I could rotate the joint, but I could not push it forward. So probably we thought that there is some pseudo arthrosis here, and there must be fibrosis also. So we should remove this much of bone to bring it down forward. So this is what we have done. This is the by transoral approach, we have removed that much of bone, and then this is what is post-operative. You can see that odontoid is still remaining a little bit. Arch of atlas is also seen, but only that offending element in between, which was preventing this movement forward, was removed, and this is completely reduced now. You see this. This is the post-operative plain X-ray. Now another similar type of boy, 10-year-old boy, again post-traumatic. You see this dislocation here. I thought I'll be able to reduce it. Joints are free. You can see coronal joints here. There is side-to-side dislocation also. So this could not be reduced by posterior approach. Again, we went transfer, removed that offending element, and then it is completely reduced and aligned. You can see this. Again, coming back, see this, we have removed just this portion. And this has moved forward. In side-to-side dislocation has reduced completely. Now this is a 6-year-old girl who had assimilation of atlas C2-3 fusion and very severe dislocation over here. And then you see in MRI the spinal cord is hardly seen here. And in CT scan there is orthodontoidium C2-3 fusion, and this is C3, which is at the level of arch of atlas. But the joint is seen nicely here. You can see joint nicely here. So I thought I'll be able to reduce it. You see, even in a 3D picture, you see this joint is seen nicely. And if you see here, whole joint surface is seen. And this C1 joint surface is vertical. If you can just rotate it and bring it on top of it, it would be normal alignment. That is what I thought. So I went posteriorly. I could easily see the joint, and there was a lot of distance between this cranium and C2. It was easy to move, but even then it was not completely reducing. So this is the one which by posterior approach I put transarticular screws on both sides, and then although it has reduced significantly, but even then there is a small dislocation here. Probably this odontoid prevented it or what, I am not very sure, but I could not reduce it completely. And then we had to do transoral surgery and remove this part of the bone to provide space. And this is the transoral surgery and reduced it. This transoral surgery was required because the patient came after about 4 months. She had had weakness in one right-sided upper limb. So therefore, when we did the transoral approach, in 2 months that also completely improved. Now this is probably the last thing which I am showing you. Sometimes we'll say transoral odontoidectomy. That is not the case. You see in this patient posterior fusion is done, only odontoid has been removed, but still the kyphotic angle is present and there is a canal over here. So dislocation has not reduced, and there is still compression of the cord. So it is not transoral odontoidectomy which is required. It is transoral decompression of the compressed spinal cord, and we have to remove sufficient bone in all 3 dimensions to be which is responsible for compression, so that the dural sac falls into that gutter which we have created. So this CV junction is funnel shaped. We should make the thing funnel shaped by surgery. You have to remove this much of bone anteriorly to make it funnel shaped. To remove this much of bone, you have to go up to here to remove the bone. So this is 12-year-old boy. You see here, preoperatively, this is the situation, and posterior fusion has been done and odontoid has been removed, but the compression still persists. So we have removed this much of bone from front, and this is CT myelogram. Long time back we used to do CT myelogram, and you see this died nicely. It has been decompressed nicely. Another case, 10-year-old girl, where again basilar invagination, posterior fusion has been done, and subsequently odontoid has been removed. It appears only odontoid tip has been removed. You will see other cuts. You see this only tip has been removed, and it appears by this. So this is not sufficient, and it's still causing pressure on the brainstem and spinal cord. So now we have removed this much of bone again, and this is the post-operative film, and this is what I was telling. The whole cord is gone inside the gutter which we have made. If we have not done that much wide corpectomy, this would not come down inside this. So this is last case I am going to show you, my 6-year-old girl, and here you see this is completely gone inside C2, 3, 4 fusion, and this lamina and parts, everything is inside the foramen magnum, and the joint I just could not make out where is the joint. Is just in the first and lateral part of the C2, 3, 4 body. There's no joint seen. So I had no other choice. I just went transurally and removed these two, did corpectomy for these two vertebrae, removed completely. You see this is post-operative, this is pre-operative, and transurally you see in axial views this much of space was created. So this is how in some patients you would require transural. So in that one should determine the direction of abnormal displacement of C1 and C2, reverse it to restore normal anatomy in all atlantoaxial dislocations. One should determine the cause of fixity and try to remove it in fixed atlantoaxial dislocation and restore the normal alignment, and then therefore so-called fixed and irreducible AAD and so-called lesion can all be reduced by a proper surgical technique. Sometimes transoral decompression may be required. It should not be odontoidectomy. The decompression should be generous. It should provide sufficient three-dimensional room to the decompressed dural sac to lie in the space. Thank you very much for your kind attention.
Thank you, Dr. Jain, for a top quality presentation. I'll ask a quick question first. I saw a patient once with a transversal odontoid, and he had absolutely no symptoms. He could not lift his head. It was the only thing he had. Is it the same? Is pain a big component of atlantoaxial dislocations, or is it immobility or lack of movement?
I just could not get the question. He has only pain.
Okay, the pain is a big component of these dislocations?
Yeah, if there is only pain and there is dislocation, we have to treat it. We have to fix the dislocation.
Okay, okay. Okay, any questions from Simon or Dr. Gupta?
Dr. Jain, very nice presentation. Congratulations.
Thank you.
You showed in your presentation, in the last slide you mentioned transoral decompression may be required.
Yeah.
However, it should be odontodectomy. Could you please elaborate further on that?
Yeah, what I am saying is most often when transoral decompression is required, it is central dislocation or axial invagination. If that is not going inside the foramen magnum, then transoral decompression would not be required. All other would be completely reducible dislocations. So if you do only odontoidectomy, you are just removing the tip of the C2, while the compressing element would be C2 body completely. Sometimes even C3 is inside the foramen magnum. So if you don't do corpectomy, you will not be doing sufficient decompression. I showed you two cases who had only odontoidectomy done, and they were still having the compression. Because the dislocation has not reduced, C2 body is still going back, so the pressure continues.
And
am I clear?
Yeah, very clear. Thank you. How much importance you give to the verticality of the joint, the C1, C2 joints? In some patients, the C1, C2 joint is quite vertical. What do you try to reduce those?
Dr. Deepak, this was in 90s when I said these joints are vertical. I have done a lot of studies. The joints are not really vertical. So if you want to say a joint is vertical, you have to give some reference point to which it is vertical. If you take X-ray or CT scan in flexion, then the joints would be seen vertical. If you take in extension, then they would be in reverse direction. If you take in horizontal only, so the verticality of joint is a very, very tricky thing. I described it long back. Then what we did is we took a reference point of C2 body and tried to see if they are vertical or not. They are not really vertical.
Okay.
So
one last question. What are your thoughts on the DCER technique? Like DCER, they talk about that you can achieve extension. In extension, the reduction of the basilar, the reduction of the AD can take place if you do a DCER. On one pivotal point, you compress, then the odontoid gets reduced easily. But in your cases, you are primarily putting in the C1, C2 transarticular screws. So how do you reduce the AD with this technique?
You see, once you open the joint, I put the patients on traction during surgery. Once you open the joint, the relationship between C1 and C2, joint is absolutely free. Okay?
Okay.
And then I have to press C2 downwards and forwards to reduce it. That is the main thing.
Okay.
And make the position whatever it is. And sometimes I have to even hold it while putting the transarticular K-wire. So in DCR technique, you are doing distraction between maybe occiput and C2, because most of these patients have C1 assimilated, right? So you don't have C1 arch and C2 lamina, which you will be distracting. And then when you distract from behind, you are actually making angle. So distance between C1 and C2 posteriorly will increase. Anteriorly, it would not increase. So it depends where you put it. So I am not very much. What I am trying to say is, you should see whatever technique you want to use it, but you should reduce the dislocation. Once you have reduced the dislocation, then you should fuse it. In DCER technique also, sometimes I have seen few patients, it's not really reduced.
Okay, thank you. I think we have Dr. Muthukumar with us. So, Dr. Muthukumar, you have any questions?
Excellent presentation, Professor Jain. It was really revealing. And I have a couple of questions.
Yeah.
The first question is, in your slides, I didn't see, even in the recent cases, probably you don't use spacers between the joints, isn't it?
Yes.
You don't seem to use spacers.
Yeah.
And almost all your cases, you had gone for transarticular technique rather than the C1 lateral mass, C2 par screw technique. Any specific reason why you do that?
Yeah, I'll tell you what. First thing is the space. I don't use the spacer because primarily I told you what I believe in. I believe in central dislocation. I don't believe that so-called basilar invagination, primary pathologies, decreased joint space. Joint space has not decreased. When you put a spacer, you are only increasing the joint space. So if primary pathology is decreased joint space, then a spacer would work. Primary pathology is posterior and superior slippage of C2 or anterior or forward slippage of C1. So if you can correct that relationship, then it would be reduced completely and you would not require any spacer. That is first thing. And the second question was about C1, C2. C1, C2 you would require to put 4 screws. If you put bilateral C1 lateral mass screw, bilateral C2 pars or lateral mass screw, you need to put 4 screws. And in transarticular, you need to put only 1 screw. So it takes less time. It is, I think it is easier than putting 4 screws. Now you avoid those venous plexuses and all those things. And even you can easily present the T2 roots on both sides. When you try to put 4 screws, there is a lot of venous moving. So I feel unless I am really forced to put those things, if I cannot put transarticular screw only, then I put the lateral mass screws.
And in those cases, not all cases of basilar invagination have symmetrical lateral masses. So what happens in certain cases I have observed, especially about 20 to 30% of my patients, they have hyperplastic lateral mass, which is often assimilated with the occiput. So that makes the surgery a little more difficult. What do you do in that particular condition? If there is an asymmetry in the lateral mass with one mass being hyperplastic, and in fact, even the pre-op CT shows that the one joint is wider than the other. So
yes, I'll tell you what. If you are talking of hypoplastic lateral mass in coronal view and sagittal view, am I right?
Yeah, that's right. That's right.
So, what I would suggest, if you make 2D pictures, if there is a little bit of rotation at C1, C2, when you take coronal views or sagittal views, they are not going through the same part of two bodies, to the same part of two. So one part may look as hypoplastic. So you should see in all cases pictures, rotate them completely and then see. Then you would see better anatomy. So the hypoplastic lateral mass is rarely seen as far as I am concerned, and then you can put the screw. That is not a problem. The problem would be only if you have to put lateral mass screw. But if you have to put transarticular screw, there is not much of a problem.
And
as long as you
can I ask one more question, John?
Yes. Yeah.
Now, what are your thoughts on anterior transarticular screw fixation? Because recently, for a couple of cases, when I had to for myelinated odontoid fractures, I had to go in, refracture the odontoid, and then I went in posteriorly and did a typical C1 C2 fusion. So once I did that, then I thought, why should I go in posteriorly when I have access to the C1 C2? If I can put in a transarticular screw anteriorly, then it should be much more easier, because you have to, the anterior retropharyngeal approach, you have to extend, and during extension automatically the thing gets reduced. So is it, what are your thoughts on anterior transarticular C1 C2 fixation?
I agree with you. Anterior transarticular screw surgery can be done. It should not be very difficult, except that you have to get used to it. It's very high. You have to retract the pharynx. But here it should be a reducible variety. You will not be able to do manipulate the joints if you are going anteriorly, as I can manipulate it posteriorly and hold the C2 spine and do.
Absolutely. That's right.
If it's a reducible variety, you can go from the neck, and maybe you can put screws. It's actually opposite side screw is easier to put. Ipsilateral screw maybe a little more difficult to put.
Little difficult to do that. That's right.
Our friend in Pune has been doing this transarticular screws anteriorly.
Yeah. I know. I mean, I just did it for refracturing the odontoid, for myelinated odontoid for a couple of cases. Then I thought maybe it should be an easy approach to do that. And then why should I go posteriorly, fiddle with the venous sinuses and all that bleeding? So your technique is.
But I would again say refracturing is easier in transoral approach. You will go, if you want to refracture odontoid, which is malunited.
Okay.
If you go transoral, it is maybe 10 minutes job only. You just go in the center.
Yeah, but what about the velopharyngeal incompetence, etc., which the patients have post-op?
No, velopharyngeal incompetence occurs only when you divide the uvula. I never divided.
Okay. Thank you, Dr. Jain. It was really excellent. One more. I have listened to your presentations many times, but this presentation was really a learning experience. Thank you so much.
My pleasure.
It's like being at a real conference, Dr. Jain. Simon, do you have any questions or comments?
Yes, please. Thank you very much, Professor Jain, for your presentation. I learned a great deal. I would like to ask a question about the needs for patients in the country regions who may not have as much imaging access. What is the minimum needs as far as imaging in order to be able to diagnose and treat these disorders, these problems, these accidents?
Well, minimum need is just plain X-ray.
Okay.
And then if it is reducible, you don't need anything else. But some patients will have very complicated CV junction anomaly. Then if you want to do a good job, then there is no question of minimum need. We need a 3D CT scan to really understand. Actually, nowadays, even molds are formed by computerized things to form the bones outside and learn to see exactly how it is. To be sure, how do you do it? Then people are using neuro navigation also to put the screws. That is another.
Wow.
So
Wow.
That is what it is.
I see. Thank you very much.
Very good, Dr. Jain. Thanks. Any more questions or comments?
Yeah, I just wanted to add, Dr. Jain very rightly pointed out, recently people have started using 3D print technology. It's a STL model based concept. We make a very high resolution CT of the patient, and based on that, the engineer can give you a plastic or a resin based model of the craniovertebral junction. And the surgeon who is not so experienced enough, like Dr. V.K. Jain, he can actually practice beforehand the kind of instrumentation he or she wants to do. And it is a new thing to happen, and we have started doing it. And neuro navigation also, nowadays we have got POAM system, or called multi-dimensional neuro navigational system, which is again a great tool to help a surgeon in deciding trajectory, because you need to have really very fine hands to putting the screw in the correct position in such a region. Thank you, Dr. V.K. Jain, for sharing your Thank you very much, sir.
Thank you, Dr. Deepak. Yeah.
Very good. Okay, Dr. Jain, thank you for being open to trying this new technology, and I hope you like it, and hope you do some more of it, and do some great teaching. You're a great teacher. So
Hope I have been. Yeah, thank you.
Thank you very much, everyone, and coming out. And we have the next presentation in about 20 minutes. Thank you.
Bye.
Okay. Okay, we're going to take a break here. We're going to start a new link. So I'm going to send another link, Dr. Deepak. And also, Dr. Janie, you're welcome to join. I'll send you a link if you want to join the next one. Okay, very good. Thank you.